Kamal sir, it's sorted.
Started? Good.
Yes.
Okay.
Thank you.
When do you want us to start? And other people have not joined in.
Yes, attendees are joining. Kamal sir, it's sorted. Yeah.
Started? Good.
Yes. Thank you.
I don't see Dr. Fogla.
Dr. Fogla is here.
When do you want us to start?
Kamal, I think you should start, otherwise people will leave.
Yeah.
Okay, so I guess let's everybody all come on.
And Kamal, be straight with us on the time, okay?
Okay.
Kamal sir, it's sorted.
Okay. Hello, everybody. I think I must, first of all, welcome all of you to this fantastic day. It's an Independence Day. It's a special day. And we are all celebrating in our own ways here. And at the outset, I must thank people from My Healthscape for organizing this fantastic webinar. We have a lovely galaxy of speakers and panelists here, and people who are not only known nationally, but they are people who are international, who have international fame and name in the topics that we'll be talking about. We have likes of Dr. Rohit Shetty, who's a I think the final frontier in keratoconus, corneal biomechanics and dry eye. Then we have Dr. Rajesh Fogla as one of the panelists. He's a world-renowned cornea expert. Dr. Natasha, I'll be giving the formal introduction later on. Dr. Natasha, again, a very, very prolific speaker, a very dynamic lady who's probably got more awards to her name than probably Amir Khan has awards in his trophies in his house. But of course, the most familiar and favorite, Dr. Gaurav Luthra, as we all know him. He's a big dynamic guy and a dear friend, old friend from college days. And not to miss Dr. Kishore. As you know, you don't go by the looks of his face and his hair. He's as young as they come, probably younger than all of us put together. And the kind of energy he has and the knowledge and the way he speaks, he's known for that. And Dr. S.K. Rao from Chennai. So we have a a galaxy of speakers, starting from Dehradun, Chennai, Pune, Mumbai, and Dr. Himanshu Mehta, the ever young dynamic surgeon from Mumbai. And I think he's the celebrity, the most coveted celebrity doctor amongst all of us. He's got likes of who's who in Bollywood as his patients, which, a lot of times in spare time, he shares the anecdotes with all of us. All of us are great speakers and great teachers. So I guess the carry home point for today for all is going to be, we will be talking about things which most of us are not talking very frequently about. Now, let us take the phenomenon of incision and blades. Most of us are so focused on webinars and conferences on talking about machines, technologies, surgical techniques, femto, and all that stuff. One of the most important things in the prerequisite of a good surgery is a good blade. Because a good blade will give you a good incision, a good track of complete path of the surgery going effortlessly. And like one of my gurus used to say, phaco is like a game of chess, where your first move decides where you will end. So that's where it starts. The incision, that's where it starts. A bad incision can give you infections. A bad incision can give you a wound leak, a very tough surgery. A bad incision can give you Desmond stairs and other big problems. And a bad incision can give you astigmatism and a lot of foreign body sensation for the patient. Now, talking about the foreign body sensation, another huge topic which is very popular and very, very well discussed nowadays, which I guess a lot of us are hearing a lot of it, but there's never enough of it available. We have likes of Dr. Rohit Shetty, who will be wrapping up the whole conversation with that topic on dry eye. And a dry eye, I guess, it's a declared epidemic now. After COVID, I think it's dry eye, the most talked about topic in ophthalmic circles. And this is one thing which is at times easy to figure out, but difficult to treat. And a lot of times it's difficult to figure out and easy to treat. And a lot of times it's both. So I guess there'll be a lot of discussions on the concept of dry eye management, therapy, the newer frontiers in dry eye. Few topics on biometric, the newer methodologies of biometry and machines available in the market. Dr. Kishore will be throwing light on that. So I guess we will have a very interesting discussion on all the topics I've just thrown light on. But most of these topics probably will not be very well discussed in depth by other people on other webinars. So this is what we decided. We will throw a lot of light on these. So with that, I guess I will just start with my first speaker, Dr. Gaurav Luthra. And Dr. Gaurav Luthra is executive director of Drishti Eye Institute, as we all know. And Gaurav Luthra is the chairman academic committee IRSI. He's a very well known and a very accomplished and a gifted cataract refractive surgeon with over hundreds of papers in international journals and over 200 papers in national journals. And the best part is he's always available for everybody at any time. He's also been awarded the Mohanlal Gold Medal for Best Scientific Paper at UPSOS, IRSI Gold Medal for 2008 Chennai, and ACOIN Gold Medal, and also the Subodh Agarwal Gold Medal Trophy. And Dr. Gaurav Luthra is going to be talking about the changing world of dry eye disease and diagnosis. Over to you, Dr. Gaurav.
Thanks a lot, Kamal. It's always a pleasure, and I congratulate Myelscape for organizing this interesting webinar, which is so different from what we are doing currently most of the time. So I hope this is going to be useful to everyone. And is my screen on now?
Yes.
Yeah. Okay. So I think what you nailed it by saying that dry eye is all around us in different ways, and we all have a flood of dry eye disease happening. So it's really changed from the time that I graduated. I was just looking back at how we were treating dry eye, and let me take you back to the 90s when Kamal and me were both in college at the same time, early 90s, and it was post-graduation days, and a lot of patients would come with irritation related ocular complaints. They came with something like a yeah, okay. So we would end up giving them, if you would remember, Kamal, GSS 20, and that's it. Anybody with itching. So it was sulfacetamide or nafazine,
Yes.
one of these things. And we would hardly, we even be looking, except unless we saw a physically evident dry eye that would be you do a Shermer's and, kind of. So I would think that our percentage of dry eye patients in those days would be as little as, maybe 1 or 2 out of 100 patients that we would actually label them as a dry eye. And look at today, I think today 90% of our OPT, we will add dry eye as one of the diagnoses for our patients. So as I said, dry eye was just a part of other systemic conditions, and it was not really a big entity of its own. And when we look at the history of dry eye disease, the first mention of our tears was recorded in 1550 BC. This was interesting for me as a water within, and in some Egyptian documents. And first mention of increased tear osmolarity was in 1941 by von Baer. And it was only in the 60s that it was discovered that a decrease in lacrimal gland secretion leads to ocular surface desiccation. And in the 70s, we recognized that the ocular surface actually as an integrated functional unit. And it was only in the late 70s that the first mention of the role of the meibomian glands in the pathogenesis of tear film loss. So I think that makes it quite clear that it's not very old that we've actually been hearing about dry eye disease. And despite a lot of knowledge today, there is really no gold standard for the diagnosis. And as this webinar continues, I think other speakers are going to really talk at length about how we can investigate dry in a better way. I'm only going to list a few things. So if I remember and look back to my PG days, as I said, in the 1990s, I remember one of the first lubricants which actually came packaged in a bottle, and we were so excited that 1 or 2 companies have started making lubricating drops with methyl cellulose, and we had I think artificial tears and maybe one more product to start with, and they were kind of sought after that, oh, we have something for dry eye, and that would be prescribed specifically. And then look at today where we are. We have, like, I don't know, I think most of us, we have it's like a flood of lubricants which is available to us, and it's so difficult to actually commit to each company person that, okay, I'll write your lubricant, and each one of them breathing down your neck with different formulations and different preparations, one better than the other. So formally, the recognition of dry eye probably took place in a good way in the 1995 NEI industry organized workshop, which was held with the intent of defining dry eye disease, which was eventually defined as a disorder of the tear film due to tear deficiency or excessive evaporation. This was the definition which came about formally. And since that time, of course, we've come a long way. And now I call it, these are pandemic times, so I call it as the dry eye disease pandemic. I would have called it epidemic, but frankly, it is actually a pandemic. It's all around, it happens all over the world, and it's all around us all the time, affecting almost all of us. When I look back at the data in India, this the interesting study from the RP Center by Dr. Tityal and Dr. Namrata and others, observed the prevalence of dry eye in North India to be at 32%, ranging anywhere from 18% to 50%, and affecting the age group, which is from 21 to 40 most often, with almost 50% people in this age group. And most often associated with video terminal users, smoking, and contact lens. These were the three things which probably increase your likelihood of developing a dry eye. And worldwide incidence in the US, at least, I was reading up some data, is in the 40%, and across the world it's quite variable. But India has higher dry eye incidence than we might imagine. And I think we all know in our own OPDs how badly it affects us. I just listed a few situations which, if you look back, you would think that almost all of every patient who walks into our clinic probably fits into one of these situations: a computer vision syndrome, contact lens users, glaucoma medications. We all know that how our glaucoma patients come back with dry eye symptoms, and we end up treating them either with minimal use glaucoma drugs and preservative free drugs. And the whole concept of preservative free, how it came in over the last few years or many years. Cataract surgery patients who continue to get dry eye following refractive surgery, we are always so careful. And in that order, LASIK, PRK, and SMILE, decreasing order, we can say that we are always looking for alternatives to decrease the incidence of dry eye as refractive surgery has evolved over the years. Another area where I think dry eye recognition has now come in quite well is children who are on treatment for long-term seasonal allergic conjunctivitis. There again, lubricants have a great role to play. The elderly tend to have more significant dry eye. So I think by definition, the elderly will be another group of patients, the smokers, those people around them, air conditioning. So I think the list is almost endless. Patients with diabetes have higher predisposition. People with rheumatoid arthritis and other rheumatic diseases will have a correlation. And yes, I wanted to add this. I end up having so many patients, who, if you just ask them if they are suffering from dry eye, just ask them how often do you wash your eyes, and they will say, oh, I love to wash my eyes. That's what we've been told by on television, on every possible yoga teaching, that you should fill some water in your mouth and wash your eyes thoroughly. And I think all of us will agree that this can be one of the big factors. And I end up asking almost all my dry eye patients how often they wash their eyes, and counsel them to stop doing that if they want to get fine in a better way. And then last but not the least, I think COVID times have really precipitated this dry epidemic. The children are taking the brunt of it, but so are all the adults who have no reason to go out, and stuck at home. They would be stuck with their phones and screens and handheld devices and their computers. All the classes happening. So many children are coming to a pediatric ophthalmology OPD with signs of digital eye strain and dry eye. So I think this has become like the killer shot for dry eye disease, and that's why our OPDs are full of patients with dry eye for treatments and for diagnosis. So I think that kind of brings about the importance of how dry eye has become so important. And these studies or these classifications which came up, starting with that 1995 one from the NEI group, and then the DUES classification. I think these will all come up during the course of this webinar, so I won't go into the detail. But when you come to diagnosing and treating dry eyes, these are very, very useful, classifications to understand, and the flow of, how you would diagnose and treat them. And there has been the OSDI, which has really been useful for us, and it can help us, do the discomfort subscale and the vision subscale, and then end up with a report which can help you, decide how you want to treat these patients. So necessity is literally the mother of invention, and there is a gamut of dry eye investigations which we'll be talking about. I'm just going to name a few of them so that for the sake of completion, you have the the lipid layer which can be checked. So these new devices which have come up have really made life easy. I have realized over the last 2-3 years that we started using the SBM, that it really changed the way we diagnosed our patients and treated our patients a much better way than we could ever do before. The tear meniscus, we knew all these things. However, it was very difficult to document them all these times. So the tear meniscus height measurements have become much easier. The breakup times, and the checking the stability of the tear film, and the blink detection rates, and the evaluation of the blinking motions, the meibography. I think there'll be a detailed talk on meibography. And then of course the MMP9 test, which can help us also decide about the whether to treat with steroid cyclosporins for inflammatory dry eye, or to evaluate further. And so there have also been newer modalities of treatment, which again we are going to listen to right after this. the EI, which is again a very useful device with the intense pulse therapy, the thermal pulsation therapies which are available today. So I think to summarize, I would like to say that the dry eye pandemic has silently crept upon us, just like glaucoma silently, is the thief of sight. I think dry eye has become one of the most prevalent things in our OPDs, and we better be well equipped to diagnose it better with modern diagnostics and then to treat them better. There's a range of treatments available today, and I think all of us need to be better equipped to handle both our diagnostics and our treatment modalities so that we can, treat our patients better. So with that, I would like to stop and request Kamal to take on from here.
I guess, Gaurav, you've done a beautiful job. The way you summarized, and I think actually you set the ball rolling for the whole conversation to go on, because you touched on all topics and you kind of just titillated the conversation. I'll just bring on Dr. Rohit on this. Dr. Rohit, you are at the forefront of, dry eye management, new therapies, and molecular studies. Do you also feel what we all are noticing, that there is, apart from the computer time, are there any other reasons which are precipitating more and more patients coming with dry eye? We can understand the screen time is, yes, there. So would you have some hypothesis for that?
I think Rohit is
he muted?
He's around, but he's muted and probably is not sharing his screen. So I think Dr. Fogla might be the
Dr.
right person
Fogla
to
can maybe answer that question. I was going to have a next question with him. Dr. Fogla, so do you think there's actually a significant surge? Are we catching it more? Or there's more awareness? Or there's actually more of dry eye which is surfacing now? Mute.
You have to unmute yourself, Rajesh.
Rajesh.
Yeah. I think it's multifactorial. So you cannot just, the increased use of screen time, whether it's mobiles, computers, more of reading, and also the pollution level outside, which is there. All these things play a role in, inducing the dry eye that you feel. And most of the dry eye is functional. At least in my OPD, if I see, I would say that the actual deficiency of tear production of the lacrimal gland, that percentage of cases are not many. A majority of them are related to meibomian gland dysfunction and infrequent blinking. And by proper counseling, improving habits, and giving supportive therapy, you can actually treat a majority of them. But definitely increased screen time is the major factor.
Anything to do with the dietary changes which we're probably noticing? Because you hear a lot of patients come to me and they say, in our time, we were taking a lot of fats and ghee and butter with vitamin A loaded in it.
Well,
any role?
It may be. People have shown that if you have a Mediterranean diet, which includes a lot of olive oil, the patients tend to experience less of the dry eye. So it may have a role to play. Even the DREAM study compared olive oil as a placebo versus the omega-3 fatty acids, and they found that both were equally effective. So it shows that if you do have a lot of these, unsaturated fats in your diet, it may have some role of protective impact. Even vitamin D levels,
of course,
that also plays a role, especially because it makes the surface a little bit more hyperesthetic. So patients, like you say, the pain without the stain, that means they don't have actual staining of the surface, but they come with symptoms which are very typical.
They're more symptomatic, yes.
The biggest thing, Kamal, that I have found ultimately are thyroid patients, contact lens users, practical life. Contact lens users, thyroid, menopausal women, huge numbers.
And I guess also probably the use of cosmetic contact lenses, which is prevalent in the younger generation.
Regular
no reason is precipitating it.
Both regular lenses and the cosmetic lenses.
Okay,
both
one thing which I have noticed is, probably Dr. Rajesh, you agree with me or not, the COVID time, of course, the screen time, and also the wearing of the mask, because when we breathe out from the mask, the air escapes from in front of the eyes.
True.
So probably a lot of people are experiencing more dry. Probably they were on the fence. They were sitting on the fence and they've just kind of jumped on this side, probably because of more evaporation and more turbulent airflow in front of the eye.
And also the sleep time is reduced among the millennials. The active lifestyle people, they sleep maybe just for 4 or 5 hours every day. So
you're telling me
I have a
17-year-old son.
They have more of the
I have a 17-year-old son who sleeps late.
He follows US timings actually. He was born in the wrong country. So
Yeah.
he's awake at
Even
night.
air conditioning at night, Yeah, okay.
Yes. So I think that's what we are coming to. The conclusion of the question is there is a definite increase in the presentation of the patients in our OPD. And of course, the added awareness which we have because of this disease, as Gaurav said, maybe 15, 20 years ago, we weren't even aware of an entity called the dry eye. And the means available to us to diagnose them and also the means available to us to treat them probably makes it shine up in our fields of vision. So I guess that's a good conclusion we have. So I guess our next speaker is going to be Dr. Kishore. He's a very senior doctor from Pune, and I'll just flash his introduction here. Just a moment, I need to go on screen share. Dr. Kishore is going to be talking about the swept source biometry and how it can enhance our clinical outcomes and patient experience. And I would say, the thing is that you could be the best cataract surgeon, you could make the most round capsular access, most bloodless surgery, most clear cornea. If your biometry is not on mark, you have an unhappy patient. So biometry is something which he's going to be talking about. So I'll just give an introduction. He's the director of Natasha Eye Care. The name rings a bell here. We will see Dr. Natasha in a little while in Pune. He's the director of Nirmaya Hospital and is the chief of the ophthalmology department there. A very senior practicing cataract surgeon, refractive surgeon since last 32 years. He's a very high volume surgeon. And he's known for his charity work, the kind of charity work he does, and diagnostic surgical camps for the needy and poor people in society. And he's received innumerable awards and accolades all over the years. So over to Dr. Kishore now, and he'll be bringing to us the newer available paradigm shifts in our biometry and how are they essential for us to improve our patient experience and clinical outcomes. Over to you, sir.
Thank you. Oh, it's my scene.
Yes, sir.
Yeah, thank you very much for kind words. And at the outset, I thank my healthcare people for making me the part of this webinar. I'm just going to talk about a swept source biometry because I have no financial disclosures, but most often we get patients like this. I mean, at that time, we had the instruments or the biometers, which we thought that probably they are going to give us. But then if you get patients like this, then our routine oil master, lens star and all that, we can't get on that. So the new biometers on the market are, if you see in the market, there are so many available in the market. Every company comes up with their new biometer. And because the ion power calculations has become an utmost importance, because patient expectation has gone very high, and then we have to come to their expectations. So your target for your post-op emmetropia has to be on your priority list. So if you see that today, what are the available, we have so many, but what are the available in the market are the IOLMaster 700, Argus Movu, Tommy 1000, and then we sent from Heidelberg is an anterior. So let us, if you see that still, this was in a paper I was just reading that is still in the press. This is in a comparison of an anterior segment measurements obtained by a different swab source OCT based biometers. So I'm just going to go detail that what is actually in a swab source OCT. If you look at a time domain OCT, which was in a very old, and then we used to have that for a old where the mirror used to move and the resolution was a little really poor. And then the Fourier domain can have this, see the mirror moves, and then you can't get an A scans which are really within a high speed. But then after that, the swab source can do this, where you can have a high speed scans where the mirror doesn't move, but you have a spectrometer which measures this. So if we understand that why it's faster, because I mean it gives about 20 decibels into 100, so the sensitivity is very, very high. And what it does, it when it gives an image, because it's in a very high speed, here we are seeing it very slow, so it just forms an A scan images, which gives an A scans, and then it forms an a B scan image. And this was in a time domain, and this is in a Fourier domain. So you can see the difference of an quality here. So I mean, what I'm just going to talk about is the OCTs. They work from an 800 almost about 1300 nanometers wavelength. But the advantage of a 1060 nanometer wavelength is that it works. It has a less of an scatter, and also because 800 works only for the retina because it's a high scatter and low water absorption, and then 1060 is moderate. So I mean it has an moderate absorption, so it can work in the anterior and the biometers and also for the posteriors, while the 1310 is the only for an anterior segment. As we go still higher up, probably tomorrow we'll have an OCT which will be having only a tear film assessment, will have a penetration of maybe about 2 millimeter or 3 millimeter. And when we have a swab source, the parameters it captures is almost about 8-9 parameters will it captures, and also it can give a scan. Like this is an image from an Argus, which I had actually in a demo with me almost for about 2 months. It gives an image from an anterior to posterior, like it gives an image from a cornea to retina. Then we have an IOL master. I'll just give a little intro about these two. So this came, the advantage of an IOL master 7, which came as a total chronometry because it does an anterior and a posterior. While if you see the comparison which was done with an IOL master with the IOL master 500 and the Galilei and manual keratometry, so the reliability of the K readings with IOL master was really very good. So these are the publications which compared the IOL master with other biometers and also the old generation of biometers. Then the Argus move, it also has an 1060 wavelength, and I mean this is the author coming which has read. It's easier to use and quicker than our lens star and IOL master, and can capture data within a dense cataract where the other two may fail. It takes hardly about 0.6 seconds to have that data. So this is in a comparison of an Argus IOL master 700 and a Tomy 8000. The biggest advantage with an Tomy 8000 that we have is that it has an automatic alignment, where the other two, they don't have it. So we're just going to talk about our, I mean, which I own it now, and then I'm really in love with this machine, which is an OA 2000. It takes 8-9 measurements just in one shot. And if you see that how it does it, I mean, it does an automatic alignment, and then you the first you get is the pachymetry, then you get the entry chamber depth, and then you get the lens thickness, and then after that you get an axial length, and then on the front surface also, because it has a topographer, so it gives you a pupil and white measurements, and also a K1, K2 measurements. Now, why we have so many measurements? Because if you have a K values, which I mean, it also has an advantage if you have an Leica microscope. So this can work like an Calista or an Varion. So you can just take the data from here and put in your microscope. And axial length and ACD and lens thickness, these all has become mandatory for all the IOL power calculations formulas. While topography, you can diagnose the patients for LASIK or an keratoconus detection, and the pachy when you plan for an phakic IOL, and then pupil diameter when you're planning for a multifocal IOL, and also in a corneal diameter. So this one machine can be used for so many. It's not only in a biometer which you have to use only for your cataract, but this can be used for so many other equipments. Now, why there is a difference between an ultrasound and optical measurements? Why you want an optical measurement? Because the ultrasound takes from an inner limiting membrane, while the optical text from a retinal pigment epithelium. So this, and also the advantage within an OA 2000 is that it also has a conversion from an immersion and a contact. So suppose you are used to a previous calculation, so you can have your data compared with a new and see that how much the reliability is improving. Now, the biggest advantage which I feel that OA 2000 has it has a built-in topography. Now, what are the advantage of a topography? I mean, it gives you three rings, which has the measurements of your K readings. Like suppose if it's in a 3 millimeter, so that means what we used to have in a contact, a normal diameter for an keratometer. Then 2.5 millimeter, which we use for an immersion, like it's an IOL master, same as an IOL master, and 2 millimeter when you have a regular cornea or an keratoconus where you want to do an biometry or an IOL power calculations. So this you can select it because it has 3 rings, and you can just select that whatever the K readings that you want to get it for. And it's displayed as a K1 and K2. It's calculated from an elliptical approximation of 32 of 256 points at 2.5 millimeter. So K1 is generated from the major axis, and the K2 is generated from the minor axis. So that means K1 will be in a flatter meridian, while the K2 is going to be an steepest meridian. So that means when you do that, so you also have to look at an axis that where you are going to put your incision, because this helps into that also. But in topography, it's displayed as an KF and KS values. They differ from K1 and K2 and are calculated by the refractive power on the 3 millimeter diameter ring. So the advantage you get both, with you can have a refractive K also, and you can have the keratometer K value also. The another good thing that I felt about this, it gives you the asymmetry index and then a regulatory index. So you can just look at the color, like, I mean, if you see as an A and comes in a green color, so that means the possibility of regular corneal astigmatism absolutely low. When you see a yellow color, and then the possibility of regular corneal astigmatism is slightly high, so you can get as a higher astigmatism, or you can get as an and in the C, when it's red, so there is a possibility of an irregular astigmatism, like you get a PMD or a keratoconus. And the new toric IOL screen, which is, as I said, that based on a Leica connection. So what you have to do is you take an image from this and put in your Leica microscope, so you can have a directly non-marker the calibration on the cornea. And then it comes within 2 pages. It has 8 different formulas. So you can have on each screen, you can have a different formula. And also you can have a target reflection also. You want 0.5, 0.25, and accordingly you can select the lens. Now, of course, it has different IOL parameters also. So that means you have to just choose your printout, what you wanted. You want a Barrett formula, you want an Olsen formula, you want whatever formula you wanted. Each screen and each IOL, you can just select those formulas. And it has a Barrett formula, and also the new version that we have got it now, it has a Barrett universal has been extended to a Barrett True K also, which is a new version of a Barrett formula. Also, it has an Olsen database, which has a database of all the IOLs which are available, and it has almost about 168 models of an IOLs which are available on this database. And it also, like IOL Master 700, it also has a silicon oil setting. So you have to just go and shift from a vitreous to silicon oil, and you can get the biometry for a silicon filled eyes also. And this is a printout which you get it. It has all the information on one page, and also within a surgeon name. So suppose if you are in a hospital, you have 4 surgeon names, they can actually select their name and their data and their surgical A constant, and then put into that, and you can just get this data. It has an average K, PECI, and everything into that. So the take-home message is the satisfactory refractive results after IOL implantation depends on optimal biometry. An accurate axial length, entry chamber depth, and the K readings are essential for all biometric formulas to calculate the IOL power. And within a common usage of an toric and multifocal, which has become a normal practice nowadays, accurate biometry has become the more important than ever to reach the patient's expectation. And the most common preventable sources that we think of for your error is the incorrect axial length measurements and the keratometer readings. But these biometers really solve all these our problems. And then we today, you talk to the patient, you are confident that what you're talking and you are going to achieve those results. Thank you very much. Dr. Kamal, you are on mute.
Okay. So I thought, sir, that was a very, very lucid description of the equipment and the way biometry has become so important tool. I remember the time when we were postgraduate students holding the patient straight and keeping the probe straight. And then we shifted from that to an immersion, making the patient lie down. And then we shifted to IL 500s. And now we're talking about, these swept source biometries. The crux of the situation is that as more and more formulas are coming in, there is so much of information which is required now because we are dealing with patients who are very demanding. And the only thing they want is everything. I think this is a past phase which me and my partner says, my patient is not very demanding. The only thing he wants is everything. So I would just ask Dr. Himanshu, do you have any experience? Because I had an experience with IOL 500. We have IOL 500s and we also have this. And this machine, I've actually fallen in love with. 99% of the cataracts, it gives me a biometry. It's yes. Seldom said no.
Yes.
And with so many variations of formulas available, combinations available, a very, very lucid printout, it's a big asset in memory. So, Dr. Himanshu, any other experience you have with other biometers?
No, I'll tell you, the biometer is like driving a Ferrari. You give my car to Schumacher, he'll be first, and you give me his car, I'll be last. So it's like that. Your machine is what you want it to be. You need to understand your machine, most important thing.
Wonderful.
Your axial biometry is important. Your every machine has a mind of its own. Your keratometer manual will have a different one. Autoref will have a different one. Topography will give you something else. Your Varion will give you something else. Believe you me, IOL Master 3 times will give you different reading. It's you and you who has to decide on whether you want to take the K reading axis from the topography or not. You don't take the K reading from that. So you make your norms, whether you want a patient to put a lubricant eye drop before your axial length. No, I will not. Taught properly. No drops to be put before you do that. Basic fundas, these are more important. The machine comes into the picture later. And as said very clearly, in the talks, that axial biometry with laser, anywhere on a mountaintop or underground remains the same, 99.9% accuracy. Question is the cornea. The question is how dry is your cornea, how well you take your K readings, how well you do the other things, and the lens thickness. And of course, you have such beautiful formula now. So you have to correlate all these things in a bigger perspective. The bigger issue and the challenge now is with the swept source, which will help us, is all those LASIK patients that Kamal has done. There's no patient without LASIK left in Delhi. Everybody is without glass. So when they get a cataract, and Dehradun, Gaurav to finish, there is nobody, everybody is without, even today he's without glasses. So those are the patients who are going to be a great challenge in the days to come, when we'll have to get your posterior K, and how will we be able to measure with the newer formulae. So I guess that true K, TK, and whatever names that we might want to give, Hill is really challenging Barrett at this point. Both of them doing a wonderful job from the two parts of the world. And I think, yes, that's what science would be all about. We have changed ourselves, we have grown, and we understood. So I guess we are on a good pathway right now.
Gaurav, what is your take? I actually feel dry eye or a bad surface plays a huge role in the way we get an end result, not only in the biometry, but also in the post-operative recovery of the patient. Would you just share your point of view on that?
Yeah, so you're absolutely right, Kamal. In fact, I think ocular surface has become such an important thing for post-refractive, post-cataract patients both, and especially that we are doing a lot of premium IOLs now. it makes a lot of difference to actually, in the preliminary checkup itself, be diagnosing dry eye and poor ocular surface in our patients, not only for a good biometry and a good, maybe a good astigmatism, calculation for toric IOLs. You need to have reliable readings, and also for judging whether this patient is going to do well with a premium IOL, and then managing dry eye post-op as well. So if some patients end up being dissatisfied premium IOL patients with multifocals and all, the problem lies with the ocular surface, and if you tend to look at that, half the problems may be solved. We may keep doing eye trace measurements and lots of other things, and if we ignore the ocular surface, there it goes for a 6. So I think all these past lectures have really raised the point of ocular surface being very, very important. We must thank the cornea surgeons for doing that for us.
Mm-hmm.
I mean, I don't think that I'll just add over here. Probably, I mean, as I said, that I'm in love with this machine. The what I do is, as Dr. Himanshu said, that you don't put. I mean, I also follow that you don't have to put on the drops before doing an oil power calculation. But the biggest advantage of this machine is it's just auto alignment. So what you ask an patient to blink it 3, 4, 5 times, and then you just shoot it, and immediately it just takes a reading. So that's the biggest advantage that I have found with this machine.
That's true, sir. Dr. Natasha is there, and Dr. Rohit, I can't see them any.
Kamal, I wanted to add a little bit about the machine. I've had the opportunity of using this. I am usually a Lenstar user, but I got the opportunity to use this biometer, and I must say that it's really fantastic. I had it for 2 months. The ease of use. It's like a small machine with a small footprint, but it has so much packed into it, and ease of use, and so many things that you can get. Only thing which I missed was at that point were a couple of things which I think have been integrated now, like some of the formulas were missing. This is about a year or two back, and the readings and all were fantastic. It was taking everything well. I only found a little bit of problem getting the printouts from the machine. So later on I was told that you can get all printouts from the computer actually, and you can customize it to give you the printouts that you want. And as far as dense cataracts go, I think it does a fantastic job, compares very much to the IOLmaster 700, and I think it's a great tool to have for the price that you can get it much cheaper than an IOLmaster 700 for that matter.
Yeah, I guess, Gaurav, I think this machine actually is the bang for the buck. And we might have done more than 40,000 biometries on this machine, and it has never kind of failed us. And now with the newer formulas available on this machine, post-LASIK patient, as Dr. Himanshu says, post-LASIK, post-RK, post-PRK, it's made the job a lot more easier. It's narrowing the gap with the newer formulas, and on single page, you can have permutation and combinations. You have surgeon specifications. So I guess the technology is really making us walk up to the path which the patient wants from us. Dr. Rohit is here. Dr. Rohit, I just have a question for you. I've heard one of your sessions, dry eye patients and cataract surgery, they are always the dry eye needs to be taken care, both in the preoperative period before you do your biometry, it's important, but also for the post-op recovery of the patient. So your take on that, dry eye and cataract surgery.
I think we have discussed about this many times, that one of the major issues is the biometry itself. The repeatability of biometry goes down, especially you mentioned about your keratometry readings. Mm-hmm. Small change in your keratometry would change a huge difference in your biometry. The other thing is, I'm going to talk about it today, about how your quality of vision deteriorates and how do you measure it. So I'll keep that question reserved for the end of the talk, for my talk.
Okay. I guess then I'll start with my talk, Gaurav.
So I'll take this opportunity to introduce Kamal. And one moment. Let me just share my screen. As Dr. Fogla said, actually I don't need a slide to introduce Kamal. I've known him since the early 90s when we studied together in Maulana Azad Medical College for our MS. But Kamal has come a long way, and I need this slide to introduce him. He has been dynamic right from the time that I met him for the first time. Found his way from Maulana Azad to Gangaram, excelled there, and then went on to partner with his friend Dr. Sood, and then set up the Sharpsight centers, of which has again come a long way. Founder medical director of the Sharpsight group, with a chain of 10 eye hospitals and 2 outside Delhi. Sharpsight also provides, has gone international with centers in Africa, Mongolia, and Tajikistan. And he has been a brilliant surgeon right from the time I knew him. All our teachers thought that he was too fast, and occasionally they were scared of holding his hand back lest he cause a complication. But that was long back, and today he's become a brilliant surgeon, teaching so many people, performed over 70,000 surgeries, and one of the fastest cataract surgeons in the country. He has been presenting papers and invited for instruction courses at almost all the international conferences, the ASCRS, ESCRS, and the world other forums, the AIUS. He is one of the favorites when it comes for being invited to perform live surgeries in India and abroad. He is very passionate about technology, and he has been working with a lot of technology, EMRs, recording devices, the USAID, making movies. He has a passion for almost all kinds of technologies, listening to, making music for that matter. He has been amazing at mixing music. I love his compositions. He's into sound engineering, also interested in Urdu poetry, photography, if I remember correctly. And so as I said, I don't need slides to introduce him. Yet, I think, Kamal, it's nice to have you, do this program today. Please go ahead with, show us what you're planning to show.
Thank you, Gaurav. And Gaurav, it's always a pleasure to have a session with you, Dr. Rohit, Natasha, Dr. Fogla, Dr. Himanshu. There's so much of cross learning, and I guess I always end up learning. I keep taking notes. You'll be amazed. I keep taking notes even during the webinars I'm conducting. So, okay, my topic is avoiding keratome-induced Descemet's detachment during cataract surgery. This will be a bit of theory, a lot of videos, and more of practical stuff. So first of all, there are no financial disclosures. I have nothing financial associated with any talk or any products I'll be talking about. So as we all know, Descemet detachment is a very, very uncomfortable situation for a cataract surgeon. He's doing a meticulous job, a perfect surgery going on, and this is what he lands up with. Bullous Descemet detachment can be a big headache. A lot of times you want your cornea surgeon to be around to help you out. You're sweating unnecessarily. And at times it can be of no fault of the surgeon. It could be just a bad instrument. And so what it is that it has been reported to occur at any stage of cataract surgery, but mostly it has been seen related to the wounds or the constructions of incisions. Now, Dr. Susan Jacob, in one of her articles in Eurotimes I came across, she's classified these detachments in 2 or 3 major categories, one being the focal DMDs and the second major category being the rhegmatogenous. Now, according to her, the focal DMDs are approximately in 43% of cataract surgeries. Now, most of them can be very small, less than 1 millimeter. You probably won't even notice. I'll show you some videos, which actually since I was supposed to be talking on this. So over the last 2 weeks, I started collecting some videos, and all the videos you see, I've collected some from my archives. So some of them might go unnoticed, but if you look for them, you actually cause that Descemet's detachment either at the side port or the main wound. Now, what you have to be careful is once you created that DD, now you have to be careful that any further aggression near that will lead to a bullous retinal detachment. Now, most common reasons are blunt instruments, suboptimal knives, at times injection of viscoelastic. We'll see some videos for that. Viscoelastic injected within the Descemet membrane and the stroma, intracameral fluid, BSS during hydration. A lot of times they will happen, suppose you are reoperating a case and you create a separate plane in a fibrous corneal wound. Now, the possible situations for a Descemet's detachment could be when we are talking about the side port. If you have a very tight side port, an insertion of instrument or your chopper or your manipulator could actually cause a Descemet's detachment, which could be a focal. A lot of times a hydroinflation of the side port at the end of the surgery, you could actually enter the space behind the Descemet's and create a bullous retinal detachment. Sometimes the main wound during insertion of the phaco-tip, especially when you're dealing with a flared phaco-tip, you need to be careful because these flared phaco-tips are known to cause more Descemet detachment near the wound. A lot of times if the wound is little tight, your sleeve tip can get engaged in the wound. So we will see some videos for that. Insertion of the IOL, a lot of times, so a lot of people are doing a wound assisted insertion or hydroinsertion of the IOL, which you'll see in the video, the haptic can actually sweep as it's unfolding and sweep out the descendants from the wound, hydroinflation of the main wound. So as I said, just a minute, I actually rewind the thing. So what are the characteristics of a blade which contribute to a descendant detachment is the thickness of the sheet, the sharpness and the angulation, the edge overplay or the edge profiling, and the surface polishing. A lot of times you could have a good blade, but if it's badly polished and rough surface, while you enter into the anterior chamber, you could cause a descendant detachment. Now, these are the most probable reasons. As I said, a lot of times this is a repeat. A lot of times there could be inherent weak attachment between the descendants of the patient. I still remember I operated a lady, mother of a very senior director in Indian Oil, and I finished the surgery and I just put in a small hydro and I could see the whole descendants detach. And I thought it was my fault, there was something wrong. So when I took up the second eye surgery after 3 months, I was very careful while doing the hydro, but I realized that even the slight movements of my instruments within the cornea or the wound was causing a focal descendant detachment. This is in spite of the fact that I was super careful. So this means there are some patients who would probably be more prone to have descendant detachment. There are a few studies which actually say that what are the kind of wounds which are more prone to descendant detachment. This is again a study by Dr. Tityal at RP Center, where he says that most common stromal hydration is 83.7% of focal descendant detachments is the stromal hydration. The rhegmatogenous descendant detachment is usually seen when there is a mechanical injury due to the instrument or the haptic sweep. But let us all understand, a poorly constructed corneal incision is the first starting of problem during a cataract surgery. We are not only just talking about descendant detachment, but leaky wounds, iris prolapse, corneal edema, and all that stuff. So let us look at the architecture of a wound. What could an ideal wound or a good blade or a good keratome help us with? An ideal wound should be as near a square appearance as possible. A lot of times you see a lot of YouTube videos where you see the surgeon sweeping the wound from side to side and trying to compensate for the thicker blade or a blunt blade. And this is what you land up with. You land up with a chevron-based appearance of the incision. We will see a video here. Now, this is a classical example. You just see my blade is about to enter and you see a dimpling. And this incision resulted into a chevron incision. Now we will see another video. You see, it's a blunt blade. I'm moving side to side. I do and manage to enter and see what I've created. There is a typical center pouting here. Can you see the central point, Dr. Gaurav?
Yeah, yes, Kamal, I can see it. Yeah.
Now, this is what a chevron incision would look like. A lot of times you would miss it if I had not stained it. If I had not known what I'm creating, I would have got away with this. And at times of hydro, since the inner lip is very thin and the descendants is very fragile attached at this particular point in the center, and here at the edge, you could actually create a descendant detachment. Now, this is the result of a blunt blade and a side-to-side movement. Now, we will go to the next position. This is another video where you have a focal descendant detachment due to a tight wound. I'll try and freeze my video there. Now, can you see a local descendant detachment here? Can you see the fold?
Yeah.
And there's a descendant detachment here. Now, this is again at the side port. Now, in case the surgeon would not have noticed it and gone ahead with an aggressive hydroinflation or hydrosealing of this wound, he would have landed up with a bullous detachment. Now, this is a bad blade which the surgeon is attempting in one go and then realizes it's a bad blade, takes that blade away and starts afresh. Now, this is again, we have two planes of tissue. You will notice a movement within the wound of another stromal tissue which has come loose within the wound. Can we see that, Dr. Gaurav?
Yeah.
There is a loose tissue which is a two-planar wound due to a reintroduction of the blade and not entering in the same plane. The reason why the first blade was pulled out was it was blunt. So this is what a bad blade can do. And this tissue would keep troubling the surgeon all through. Now, this is again another wound which is bad constructed. It's a shorter tunnel. It's tight. So see what the sleeve while entering the wound does to the descent membrane. Now, this will be again a high magnification video. See what happens. The sleeve is tight. It's getting stuck up at the wound. And there. And now see, since I was aware I might have caused some problem, and you will see, I'll freeze the video somewhere in between, and you should be able to see the descents flapping there. I'll just forward the video. Now you'll see the descents. Now, can you see this fold?
Yeah.
This is what the sleeve did. It was a tight sleeve. The surgeon is me again, tried to push it through. I was a little aggressive. I could have probably waited or maybe positioned the entry point of my irrigation aspiration port. But now, since I was aware, I have to be very careful when I insert the IOL in such a situation, because the IOL in the wound assist technique, while inserting or even the sweeping of the haptic, can actually cause a complete detachment of this descent. Now, bad blades give you uncontrolled incisions. A good form could be always that you should have a radial entry. It should go straight in and straight out with no sideward movements. A proper width will give a less astigmatic effect. But a lot of times when the surgeon is moving the blade from side to side, you will have an irregular entry, which is an angle or an oblique. So we will see some still photographs of that. Now, let's see this. A bad blade, once it goes in, this is what it does. It creates a crooked, uneven shape and creates a bevel inside or a chevron-based incision. So this is a chevron-based incision. I hope on the Zoom video it is visible. Can you see the apex of the incision? Dr. Gaurav?
Yeah, I can. Yes.
And this is an oblique incision where the blade was being swept from side to side and you have an irregular entry. Both these wounds not only are scarred, unsightly, but they would also induce astigmatism and be unsteady and unreliable. This is again a video. So I'm just trying to show the bad ones first. This is a blunt blade. You will notice that I need to support the eye from the opposite side to make sure that the blade enters and we create an entry. But though the entry looks normal, but we will see the scar on the eye after a few days. After the second post-op visit, we will see the slit lamp photographs. Now this is the time, a lot of times the patients will have dysphotopsia. A lot of times these scarred wounds, which have longer tunnels because of side-to-side movement, will cause dysphotopsia to the patient. Because this scar shadow, as I'm moving the slit lamp, you will see that the shadow extends till the pupillary zone. The same goes for this. So again, situations in post-RK where, a blunt wound making incision, you can actually dip in and cause the cornea to open up. This is a DMD post-descent attachment. This is again DMD at the wound. Now there are some videos which I took from the YouTube for our audience to see. Now I will just point out, you have to watch out this area. There probably was a small DMD here. The surgeon actually accidentally pulls out the hydrating part of the bimanual irrigation aspiration and just manages to push some fluid into the descent space and see what happens. Now watch this area. Everything is fine till now. See, there. The surgeon just pulled out the irrigating part, went into the area where there was a loose descent flap, and this is what happened. Now, this is again another video where there could have been a descent detachment at the side port. There, you see a bullous retinal descent detachment. So before we do aggressive hydrodelineation, hydroinflation and sealing of the wound, we have to be very careful that there are no descent detachments sitting there. Again, visco injection under the descents will cause this. So there you see viscoelastic has caused this. Now this is a thicker blade with a premature entry, and see what it has done. We have an iris prolapse with a gaping wound. Again, a thick blade. So all these things. Now, how are the blades, good blades, made? Good blades are not manufactured from sheets. They are manufactured from wires. They are compressed by pressing on wires, unlike other blades which are made from sheets after heating them. And as it is told that the sheet, when it is heated, it can cause uneven sharpness and uneven strength. But in money blades, which I use a lot of them, I've shifted to money blades. And even for my femtocataract surgeries, I'm using a lot of money blades now, because a lot of times the incision would not open. And even if it is tending to open, I prefer and I feel I get a far more controlled incision with a money blade. They are made by beating and pressing onto the wires. No glare, good polishing, and the surface edge. Now, the trick of these blades is the way they are shaped. They're cross-lap edged. They're very sharp. They're, I think, as sharp as diamond blades, because I've been using them for probably 1.5 years now, and I'm very happy with these blades. And in fact, most of my femtocataract surgeries I'm doing using these blades. Now, the difference, the trick lies in the bevel and the profiling and the angulation of the blade. Now, we will see 1 or 2 videos, and that should finish my talk. The edge part. Now, this is a video again with a money blade. Now see, no pressure, no side pressure, and the wound is just clean. Once the wound is made, you can't even spot the wound. How beautifully the wound has been made. The inner lip is distinct. There's no descent stretch. Now, this is a high myopic patient. You can see no need to hydrate the wound. I will just use an hydroinsertion. You can see the IOL actually stands vertically in the anterior chamber to show how myopic the patient is. And I will not need to hydrate the wound at all. I will just pressurize the chamber, and that's it. The wound is sealed. I think that's one classical definition of an ideal keratome. So this is another femtocataract which here I'll be using. No pressure, no counter pressure. You just hold and push, and you have a clean, smooth entry. Again, this wound will not require any seal or hydration. Again, we use the hydroinsertion, putting in a multifocal lens, and the wound is not hydrated. It is going to seal. We just insert some fluid into the eye, hydrate the side port, and the surgery is over. So what it does for the patient is the hydration, no need for hydration. The patient has a better vision, a clearer vision, and a faster recovery. So thank you. So Dr. Himanshu.
Yes.
Incisions, importance of incisions.
First, I wanted to comment, brilliant presentation.
Thank you, boss.
One question, it was not only here you were aggressive, overall always you've been aggressive. So I compliment you on that. Of course, if your incision is not good and if your rhexis is not good, your surgery is gone, period. So the first part is the incision. If you don't have adequate space, if it's not the right size, if you don't know your phacoprobe size, it is just the end of your problem. I mean, just the whole surgery will get into a mess. So I totally agree, a smart, smooth blade. You know, classically, all the residents, they get the 4th, 5th, or the 18th case. That is the worst thing that a resident should be getting. Absolutely. They should be getting a new blade. And this is what I keep telling them, you know, because that's the way they will be learning surgery. Or poor children, they get messed up in their surgery because the wound creation is only bad. So the beginning, a good step is 60% job done. And the next 20 with the rhexis. So I think the very important that we have a good blade, sharp entry, and don't worry about the cost. It gives you fantastic results. And you'll be more than happy.
Dr. Kishore, any experience and any comments on the blade I just discussed?
Yeah, I mean, I use money blades since last about 3.5 years now. And I mean, I have never felt that I have to change or I mean, to be very, very honest with you, when someone said me that, you get an incisions with femto, so I said the incision that I get with the money blades, even your femto cannot give it. They're
I
so
agree with you.
perfect. You just go smoothly, just pass it on. It's like how you say that, when just going through the butter. It's like that. You don't have to really, really stress or push it that it is going to go. It just gives you, the only thing is you have to understand that how I mean, you have to just make it like this, that you get exactly, a rectangular where you don't have to. And I have never, so many people who come for a fellowship or an observation, they ask me, so why don't you highlight your main entry? Everyone does it. I said, I have never felt the need of doing a main entry dehydroinflation. Side ports you do it because you have the side ports which goes through that and it makes that round tunnel. But in the main tunnel, I've never done a hydroinflammation because I mean that's an actually the place where you get the descent detachment.
True. Dr. Natasha is there? No, I don't see her. Dr. Fogla, experience with these blades? Oh, she's there. Actually, people are not on screen, so a lot of times I don't know whether they're there or not. Dr.
No, it's just-
Natasha,
Yeah.
you use these
Okay,
blades?
sir.
Well, sir, the cataract department is dead, so I think he's given a wonderful justification for it. We don't step on each other's toes.
One beautiful thing, Dr. Fogla, is once I see the patient on slit lamp the next day, in my experience, it's difficult even looking for the incision once you made it with this blade, even on the first day post-op.
Completely agree with all the points that you've made. And we do come across complications of DM detachments, which are referred to us for further management. And often the starting point is a bad incision where you have created a DM detachment, a focal DM detachment, and then subsequently when you go in with your probe or you try to hydrate your wound, you end up detaching the decimus membrane. And at times, unknowingly, you might even catch the decimus in your phaco probe or IA probe and eat up a piece of the decimus membrane, and then you have post-operative diffuse
You bet. Yes.
The only one point that I would like to make, even for residents who are in training, is that, see, the tendency when you do a cataract surgery is to make your side ports first. And then you fill the chamber with viscoelastic, and then you go to make your main incision. Now, the trick to get a good incision is that you need to have a firm eye. If your eye is soft, then you find that it takes more pressure to get the blade, especially if your blade is not as sharp as the money blade. The other blades, you have to do a lot of manipulation. Sometimes you have to move the knife sideways to be able to. So that's not the ideal way of the incision that should be made. And often it also makes a very long tunnel than what is desirable. So always pressurize the chamber very well, and then try to make your main incision, and you will ensure that you get a proper incision which is of the right dimension and is not larger than what you would have wanted. And even when you go in with your probe inside the eye, don't go with the irrigation on, because if you do have a small detachment because of the fluid flow, you'll end up enlarging that detachment at that point. And if you feel that there has been some, even if there is a partial or a small detachment close to the wound, there is no harm in putting a mid-size air bubble in the anterior chamber at the end of the surgery, because that small air bubble in the anterior chamber, when the patient is sitting up, will ensure that the small partial detachment that you have, it gets secured very well, and your patient doesn't have a focal edema around the incision site, which takes maybe a week or 10 days for it to resolve.
Wonderful. So I guess
Dr. Kamal, there's a question for you. It says, can you elaborate exact movement of the blade? I mean the plane wise, that is straight and down, or up, straight and down.
Okay, I think it's a very good question. I used to make triplanar incisions to start with, where I would have one incision at the clear cornea or just mid limbus, which is exactly perpendicular to the plane of the tissue. It would go approximately 60% to the depth. And from there, I would follow the plane of the cornea from the limbus. And then just approximately 1.75 millimeters, I would make a dip in. That's what I was making an earlier triplanar wounds. But for last 2-3 years, I've realized a triplanar wound or a good biplanar wound with a good blade is as good. Because sometimes when I'm making a triplanar wound, and since most of our surgeries are topical and the patient moves, you can end up making a deeper wound. A lot of times have a chevron incision or probably injure the capsule itself. So I've stopped doing that because a lot of times you have those itchy and jumpy patients. So I make a biplanar wound just at the junction of the tissue. My first incision is perpendicular. Then I follow the path of the cornea, which is approximately 60 to 70% of the depth of the cornea. And then I straight enter at an angle without depressing in the center. But yes, for beginner surgeons, making a triplanar wound is far more a good idea because they are far more sturdy, because then you can actually balance the thickness of the roof and the floor. So triplanar wounds are known to be more sturdy and astigmatic neutral, but over time as you move, you can shift to biplanar wounds.
Yeah, but Dr. Kamal, what do
Another-
you have an opinion about astigmatism within a bipolar and in a triplanar? Because triplanar will give a more astigmatism as compared to a biplanar.
So the reason being the roof of the triplanar is as thick as the base of the floor. If you want, I can actually go back to the cut section which I showed. So the wound holds better. But when you have a biplanar wound and if you actually overpressurize the eye, the detachment tends to slip over and underlock. And when it underlocks and then the fibrosis happens, you could probably have more astigmatism. So for a beginner, because for a beginner to titrate the post-operative pressure of what he leaves the eye, if the biplanar wound, the inner lip is thinner, and when the pressure goes up, the inner lip of the detachment sites can tend to underlock and slip. So this is where you can probably have a flatter meridian. That's in my opinion.
One point regarding the money blades is that they are super sharp. They make beautiful incisions, but they are very, very fragile in the sense if your nurse is not very careful, you can find that by the time she gives you the knife, the tip is slightly bent and you find that it's not performing. So you have to be very careful with that. So I often tell my nurses not to remove it from that casing that it comes.
Yeah.
So I take the casing, I remove it myself and then use it, because they have a tendency to remove it and keep it in the tray. And if it touches any other instrument or any other thing,
it's finished.
The tip gets, so that's the only downside of the money knife.
I completely agree, Rajesh. In fact, exactly my thoughts, because, I often tell them that, don't take off the sleeve and give it to me and however, here I would like to point out that all these blades, I mean, the good quality blades, including money, they come with that protection sleeve, which, kind of protects the blade. So I think that's a great thing, which is not available on all the blades.
Yeah, that's from BD. If you see, they have a very nice retractable sleeve.
Retractable.
So whenever you're going to use the knife, you can retract it, use the knife. So I think just that it costs a little more. So, but if people who make beautiful blades, if they introduce that concept like a retractable sleeve, so that if you remove it from the packaging.
Rajesh, it's there on money. I used them for a long time, last 2-3 years. Money comes with those things. They're slightly more expensive, but then they tend to last so much longer. We've been using plasma sterilizer, or even
you can always, if the tip is not damaged, you can always
10 patients without realizing it goes still like as it's going through butter.
Yeah,
so I think money has that big advantage. It comes with an even better sleeve than BD. I was using BD for many years till a few years back I switched to money, and I think no looking back, money is fantastic.
Wonderful. Yeah, and with plasma sterilizer, I agree with you, Gaurav, it can be recycled.
Yeah. Yes.
So, okay, I think it's a very extensive discussion on that. And now we have to introduce the star speaker of the day, the celebrity speaker from Mumbai, Dr. Himanshu Mehta. He himself looks like a hero. And I couldn't imagine, I was seeing his two daughter and son, I believe, by his side, and they probably look like younger brother and sisters. So Dr. Himanshu Mehta he's the director of Vision Eye Center, Mumbai. He's trained with Dr. Charles Garcia in Houston, USA. And he is always full of energy and always smiling. And I'm sure that's the reason why he gets all the pretty actresses from Mumbai visiting him. Probably they come to look him up more than show their eyes to him because of his vibrant personality. He's a very proficient cataract and LASIK, glaucoma, squint, vitreoretinal. Anything else left? I think maybe oculoplasty. I'm sure he'll try that also. He's done published a lot of research papers nationally, internationally, and he's a speaker at various forums on international forums. And he's been actually felicitated by the great Dalai Lama himself. And he's been awarded the prestigious gold medal for his contribution to ophthalmology at IRISI refractive surgery at Chennai. So over to Dr. Himanshu, and he'll be talking about the tear breakup time. Dr. Himanshu, over to you now, sir.
Thank you very much, Kamal, for a wonderful introduction. आपके मुंह में घी शक्कर, with all those pretty babes that you're talking about. कहीं ना कहीं सच हो जाएगा. But they're all right now with you. Thanks so much. Having a wonderful time here. An excellent video that we have. We had good presentation. Things are going so well. Here is a very interesting presentation that you've given me to talk about dry eyes. The talk of the time today in the corona times. What we are looking at. Tear film breakup time. Very important, very, very important scenario. This is what happens.
Start sharing your screen, boss. We don't see the screen share. Okay, now got it.
So this is what is missing actually in life. and which is why the tear film breakup time doesn't happen. You see that? Yeah. So with excessively watching television, your high screen, your phone, computers and your WhatsApps and your Facebooks, every which way, people have stopped blinking. They are glued to their television. They're glued to their phone. They're glued to their smartphones, every which way. Instagram, you can't miss what somebody else is doing or cooking. So every minute the eyes are exposed. So the tear film breakup time, which is there because of the blinking, very intermingled with that. So several factors are involved in the pathology of dry eyes. Most important is disturbance of the tear film physiology and, of course, clinically evident drying of the ocular surface. Blinking plus tear film are responsible for the protection of the ocular surface. So both are equally important, blinking and the tear film. So we'll talk about, my talk would be on the blinking rate. The blink rate is altered in the following condition. Average, we have about 8 blinks per minute, which means about 12 seconds we blink every 12 seconds. And if you're watching something very interesting, you might just do it 2-3 times. That's unfortunate. Environmental condition, air conditioning, heavy winds, cognitive activities, visual task, emotional status, diseases, as I said, thyroid, menopausal women, they all have problems, ocular surface conditions, LASIK cataract surgery. How often every cataract surgery, boss, you after a deadly surgery Kamal has done with a 80-year-old brown cataract, shallow AC, one-eyed patient, he has done a wonderful job. You know what? After 10 days, she fails. Doctor साहब surgery अच्छा नहीं किया आपने. आप फेल हो गए. आप मुझे खटक रही आंखें. आपका लेंस खटक रहा है. Now she's seeing very well. Everything is perfect. But the biggest thing that comes in your way is the dryness and the tear film breakup time, which is responsible for us to get to our problem. So what are the factors which are affecting blinking? Alteration in temperature, humidity, lighting condition, airflow directly facing the air conditioning, and the cognitive activities, visual task, emotional states. That is, during the conversation, during intensely focused, when you're concentrating on somebody, listening to somebody intently, you tend not to blink. So during intently focused visual tasks like emotional excitement, anxiety, frustration, guilt, everything goes for a toss. So there is a huge psychology element involved in the tear film breakup time and the blinking phenomena. Factors affecting blinking, diseases and medication, Parkinson's, diabetes, thyroid, ophthalmology, schizophrenia, blepharospasm, ptosis, psychoactive drugs, muscle relaxants, thyroid. I keep repeating because that's very common in women and a lot of men also have thyroid problems. So the blink rate in dry eye with reduced corneal sensitivity is 3.2 times per minute, a reduction of about 57% versus normal people, which is huge, Now look at the tear film breakup time. As you blink and you open, and as you can see the black areas coming up, that's the area where the ocular surface is exposed to without any tear film. And that's what is going to give you the problems. So tear film and blink both have a role, as we discussed. Tear film, the ocular surface homeostasis, moistens and lubricates, transports nutrients and oxygen. Whereas the blink removes the debris. It's like, remember, I keep telling patient that on your windscreen in your car, it's your wiper which is not working well. During monsoon, if your wiper is not working well, you will not be able to see clearly. What this does is it makes lovely tears which spreads properly and you have an even feeling. And that is the most important part of blinking. The wiper was given to you free of charge. You just did not have to mess it. 8 times per minute, subconsciously, we were doing that very well. It helps in discharge of the meibomian gland secretion because every time you do that, there is pressure on the eyelids and you can have the meibomian gland secreting the lipid. So it distributes the tear film and helps formation of the tear film and not allowing it to evaporate because the basic ingredient of the lipid layer, the aqueous layer and the mucin layer. Once that gets disturbed, we have problems. So in addition to tear film, blinking has a role in ocular surface protection. However, the tear film breakup time is more commonly used in assessment. Its T-bar is insufficient. Its common parameters for dry eye assessment, quantification, does not factor in the interblink interval. Now, this is a very important point that I wanted to mention. We keep talking about T-bar, but there is something more important. IBI, the interblink interval. So, how much is the interval between two blinks, or the duration on which the ocular surface is exposed after the T-bar? So, once you have blinked, how much time are you exposed to the foreign, the wind, the temperature around you, the dust, dirt particles? So blinking during various activities, resting is 8 to 21 per minute. Computer, when you start using intent study, then you're listening to Kamal's talk, it is less than 4 times. During conversation, when you are tense and you're proposing to your girlfriend, it is 10.5 to 32.5, or when you are lying. Reading your newspapers, 4.5 per minute. If you are reading about the stock market when the market is going down, it's even less than that. You can't just close your eyes. And blink rate decreases 5 while watching television, a display unit, a visual display unit. So LASIK, of course, we all know LASIK has been blamed plainly for disrupting the corneal sensitivity and the iatrogenic corneal nerve damage, the plexus which is damaged, the corneal nerves which are creating a problem. The other factors that may cause dry eyes is the damage to the goblet cells, which occurs using the microkeratome. There is a post-procedure inflammation of the ocular surface. So we can blame LASIK for multiple issues. But I tell you, in personal experience, the worst has been actually the patient. Most patients who complain are LASIK patients, are the cataract patients. In fact, quite a few of my contact lens using patients who have done LASIK surgery have stopped complaining about dryness because the cause of contact lens has been removed. So the worst are the cataract patients, and they keep cribbing for 6 months that they have pain in the eye and that you have big problems. And that too with a 2.2 millimeter lovely sharp blade incision. Now, what Kamal said, the previous talk, how important it is the incision, because if you don't want to have an uneven incision, a jagged incision, or rough incision, the sclera and the conjunctiva and the cornea being messed around with a lot of inflammatory cells there, if you don't have a smooth incision, you will have a lot of inflammatory areas and a lot of inflammatory cells, which will give rise to dryness and give patients the breakup time. It will give like a foreign body sensation. So the STBAT is insufficient as a parameter. The number of seconds quantifying a patient's tear film breakup time provides insufficient pathophysiologic information for the clinician to fully understand the nature and severity of the cases of dry eyes. The concept of ocular protection index, very important again, to quantify interaction between the tear film breakup time and the blink rate. As I said, tear film breakup time, interblink rate, and the blink rate, a concept called as ocular protection index, or the OPI, was developed. OPI provides an essential tool to assess the association between the tear film stability and the dry eyes. As you can see here, that the tear film breakup time and cycle repeats. If the T-bar is less than the interblink, if tear film breakup time is less than the interblink interval, ocular surface remains exposed after the film breakup. And that is where problems start. The red signals and the red flag starts doing that. And consistent break time, blinking time increase gives rise to a lot of dryness and inconsistency in the tear film. Factors that shorten T-bar and prolong IBI can damage the ocular surface. So how do we calculate the ocular protection index? The OPI is calculated by dividing T-bar by the IBI. It's very simple. So it's no big deal. Tear film breakup time upon the interblink interval. So when you see that, step 1, step 2 is calculate. So if you have result of less than 1, unfavorable, as ocular surface is exposed, and if it is more than 1, favorable, because the tear protected ocular surface. Clinical relevance of the ocular protection index. It indicates dry eye severity. OPI may indicate a person's risk for development of dry eye signs. Degree of discordance between the T-bar and the interblink interval measured using the ocular protection index suggests the severity of patient's dry eye condition. OPI can help identify a person susceptible to dry eyes in absence of symptoms. Very important. An educational tool. We can have a very important thing to educate patients when they take their own video as to see what is the interblink interval and the ocular protection index can be shown to them that how they're protecting their eyes. Treatment. OPI enables measurement of effect of treatment on the ocular surface, unlike the T-bud. The ocular protection index also enables evaluation of integrity of the tear film in response to the treatment, and it is a good parameter for evaluation of effects of treatment in clinical research. Ways to improve the T-bud. The ocular protection index. It's very, very interesting. Such small things can change. Yeah. So it's the OPI indicates a dry eye severity. It may indicate a person's risk. Can be effective tool. And ways to improve the T-bud. OPI can be increased by increasing the blink rate. Simple. The first video which I showed, more winking from college time to regular activities can help you, blinking and winking, or increasing the tear film breakup time. Increased blink rate needs subjective efforts. To remind somebody to breathe deep regularly like a pranayam is an effort, because we subconsciously breathe, 1/3 of our lungs are filled up, but you have to tell somebody to make it a habit, and a habit takes about 3 weeks to form for any kind of substance. So which is what we have to teach these patients the first thing, including when they come for our A scan, to blink properly, make them blink, squeeze their eyes, and then do our A scan. So it's a very important thing which we miss out in clinical practice because of the lack of time. But tear film breakup time is very important, and can be increased by use of artificial tears. That is, you change the tear film besides changing the tear film breakup time. So as we can see, there is a great relation between tear film breakup time and the blinking. Is a measure of both tear film stability and ocular surface. Improvement of OPI suggests positive impact on tear film stability. And PEG, HPG, all possible things that we have can help us treat the ocular surface. Over to you, Kamal. This is to tell you about the tear film breakup time that I wanted to talk a little more about. Kamal, are you there? Yeah.
Yeah, sure.
Yes.
I'm there.
Yeah.
Thank you, Dr. Himanshu. I think I must take this opportunity before I introduce Dr. S.K. Rao. I must have the opportunity to welcome Mr. Shingo from Money, who's the president of Money, the India counterpart, and also the application specialist, Mr. Simone from the SBM, Italy. They are on board because we can't see them, but I'm told that they're on board. So let's welcome them before I start with Dr. Rao. Dr. Rao, are you there?
Yeah, I'm here.
I can't see the video.
I'm here. Hi. It was off. Yeah.
Okay. So I'll just go on to the brief introduction of Dr. Rao. Dr. Srinivas Rao is from Chennai. He's undergone training in Boston. There are a lot of surgeons, big surgeons here, trained abroad. I feel slightly small. He's been trained in phacoemulsification in Canada and LASIK in Minneapolis. He's lamellar corneal surgical training in Rotterdam. I think there's no country left. He's certified for advanced IOL surgery and alpha-core prosthesis, and has been trained in epidemiology and biostatistics. Wow, at Estelle Donny, California. Attended more than 150 national conferences and more than 40 international conferences. Over more than humongous 300 lectures. Published 182 papers in peer-reviewed journals, and authored more than 20 books. Reviewer for 10 peer-reviewed journals, anterior segment section editor, and he's got outstanding service and prevention of blindness and APAO, and also an oration award in 2006, Rustam Ranji Oration Gold Medal. So I think that's a large list. Over to Dr. Rao, and I was not interacting with Dr. Rao earlier because I couldn't see him on screen. I was wondering whether he's gone there or not. Dr. Rao, over to you for your topic.
Yeah. Thank you, Dr. Kapur. Can you see my slides now?
Yes, very clear.
Okay, thank you. This is a fairly important topic that's been gaining precedence in the recent years. And for those of you who are interested in reading more about this, basically, There was one entire issue of the IOVS in 2011, which was dedicated to various aspects of meibomian gland disease. And I'd like to acknowledge that some of the pictures that I'll be using during the talk are from that journal, because I find that they're the most representative of what I would like to say. So for those of you who are interested in understanding a little bit more about meibomian gland dysfunction and its management, this would be a good resource for you. So in order to understand meibomian gland function, only then can we then go on to managing its dysfunction. We need to look at the anatomy of these glands. There are about approximately 25 to 30 glands arrayed in each lid. They are placed vertically and they open on the lid margins, and we know that. They produce basically a complex mixture of protein and lipids, and there is basically a predominance of unsaturated long-chain fatty acids in the natural secretions that they make. And this is important because the eye tolerates these products very well, and when the composition changes, we can have problems. The function of the meibomian glands and the oil that they produce is to decrease the evaporation of the aqueous layer of the tear films, so that between the two blinks that we heard Dr. Mehta talk about, the tear film remains intact. If you do not have the protective oil between one blink and the other, there's a rapid evaporation of the very thin film that you have, and then you can have problems. The oil also helps you preserve a clear optical surface, and it forms a barrier to protect the eye. So this is as far as the gland function. So we then need to understand what happens when there is dysfunction to these three elements. So if you look at the anatomy, there are various conditions, disease conditions that can cause a destruction and atrophy of these glands. And this picture here of the lower lid of one eye of a girl shows a congenital maldevelopment and absence of the meibomian glands. There is just one distorted gland present in the lower eyelid. And in this context, if there is very little oil that is being produced, obviously the tear film will suffer. In disease, basically the long chain fatty acids that are present get broken down when there is excessive bacterial colonization of the lids. The bacteria use the oil as an energy source. So they then break them down into short chain fatty acids. And this change in composition, the eye does not like. The surface finds it very irritating because these short chain fatty acids and triglycerides cause a lot of inflammation and irritation on the ocular surface. And obviously, when you do not have enough oil, or when you have excess oil as well, the oil contaminates the ocular surface, and then the breakup time will suffer. And then you can do this kind of an NIBUT, and it shows you that the breakup time is very short, and this will have its own implications. So in order to assess this dysfunction, it's quite simple to look at the normal anatomy by just flipping the eyelid and looking at the palpebral surface of the lid. You will be able to appreciate these little yellow worm-like structures that are present, which are actually the meibomian glands. But if you have access to a meibographer, an infrared device, which images this, then you can look at this in far greater detail, as you can see in the lower picture on that slide. And this will help you assess the number of glands that are present, the structure of these glands, and to some extent, the function as well. When you want to look at the physiology of these glands, which is basically the secretion that it produces, this is a spring-loaded pressure device, which is devised by Cobb and Blackie. So this produces a graded amount of pressure on the middle of the lower eyelid. And then you can assess the number of glands that are actually expressing the oil, the amount of oil that is coming out, and the quality of the oil that is being expressed. But you can do this just as well with your thumb. You can just put your thumb and put gentle pressure over the lower eyelid. Normally, you encompass between 4 and 5 gland openings with the thumb, and then you can see how many of them are expressing oil, how much of oil, and what is the quality of the oil. Now, the other aspect of the function is the protective film that it forms on the surface. And in order to do this, you need an interferometer. So this will tell you the quality of the oil on the tear film and also the thickness of the oil on the tear film. And this is quite important, as we shall see in other for various functions on the surface. This is clinically very difficult to reproduce, unlike the pressure test, which you could just do for the physiology. But if you have a lot of oil on the surface, sometimes you can see these interference fringes, these rainbow-colored hues on the tear film, and that tells you that there's a lot of oil on the surface, but this is not a very reproducible test. Now, when we have the secretions that the glands make, so in the upper picture, you see that when you put pressure on the lower eyelid, normally you will see a small bead of clear fluid that comes out from the gland opening, and this is how it normally works. But in meibomian seborrhea, as in the lower eyelid, when you put pressure, you may see actually a gushing of a clear fluid, an excess amount of fluid, and this is called meibomian seborrhea. If you put pressure on lid and you see this kind of Colgate toothpaste kind of stuff actually squeezing out in little worm-like ridges. This is basically an inflammatory change in the glands, and this kind of inspissated material we term meibomitis, where there's a lot of inflammation, and each of these has different implications. And the third variety is when you see these glands which have shrunk down to pinpoint openings, and when you look at the lid itself on the inside, you can see hardly any glandular structure. So here, for some reason, disease has resulted in destruction and atrophy of the glands and cicatrization of the openings. And here, no matter how hard you push, there will be no oil that comes onto the surface, and this is called meibomian sicca. So these are the various types of dysfunction that can occur as far as the secretions are concerned, and this has important implications in the management as well. So typically, when you have meibomian gland dysfunction, the lids will also undergo dysfunction. And as you can see in this cartoon on the left, there's an inflamed lid, and on the right, it's normal. And this is how an inflamed lid will look. It will be thickened. You will see a lot of vascular dilatation on the lid margin. And you may see these kind of meibomian gland oil capping the various openings of the glands. And the posterior lid margin may be rounded as well. And sometimes you will see this kind of a froth. This is because when you keep blinking and agitating the oil, due to the change in the quality of the oil, it froths up like this. And so this kind of froth on the lid margin is typical of meibomian gland dysfunction. So this is the posterior lid margin where the meibomian glands are. They are often associated with anterior lid margin changes like seborrheic blepharitis and staphylococcal blepharitis. And we call it the triple S syndrome. Usually when there is seborrhea, there is also sicca and staphylococcus, and these three tend to work hand in hand. So these are the changes during dysfunction. So what exactly does it imply as far as we are concerned? You can also have meibomian plus disease, meibomian gland plus disease. These are due to the changes that actually happen in the gland. So because of the excess oil production and the infection that tends to set in, you can get chalasia. You can get corneal changes when these inflammatory products come onto the ocular surface. You can see the conjunctival inflammation. You can see the inferior corneal infiltrates. These changes, which are typical of staphylococcal immune keratitis, are typically seen in the inferior cornea because they are in closer proximity to the lid, and the tear meniscus, which contains all of the toxic substances from these inflamed glands. And you can see these kind of sleeves, the cylindrical sleeves on the lashes. And this is suggestive of Demodex blepharitis, which can also occur in conjunction with meibomian gland disease. So when you have seborrhea, when you have excess oil coming onto the surface, it tends to break through the tear film and contaminates the corneal epithelium, making it a hydrophobic surface, which it cannot retain the water. And then you get the short BUT type of dry eye. So these people will have a normal Schirmer. They may not have much fluorescein staining of the corneal surface, but if you take the time to look at the BUT like Dr. Himanshu showed, you'll find it's very short. And these people will complain of a lot of irritation on the ocular surface and blurred or fluctuating vision because of the poor quality of the tear film. When you have a sicca, when you don't have enough oil protecting the tear film evaporates, and between blinks, it is no longer present. It is no longer protecting the corneal surface. The corneal surface effectively dries, and over the course of time, there is epithelial damage and death, which is typified by this type of typical staining with fluorescein, which we term superficial punctate keratitis. And in the meibomitis or the inflammatory variety, when you have a lot of inflammation in the oil, which is then coming onto the surface, you can either get conjunctival flictinule, as you can see on the left, or if it goes on to the cornea and you don't manage it adequately, a lot of collagenases are produced from the inflammatory mediators, and you can even have an inferior corneal perforation from the lid margin changes. Therefore, when we talk about the treatment, we don't really have one treatment, one magic bullet that treats everything. We have treatment principles, which are guided by the quantum of oil that is being produced, the quality of the oil that the lids are producing, and the inflammation that is associated with these changes. And essentially what we are managing is this. So therefore, if we understand these principles, we will be able to manage the meibomian gland dysfunction as a whole. So when you have excess of oil being produced by the lids, we need to control that and reduce the quantum. We need to squeeze all of this excess oil out of the lids. We typically do this by first using warm compresses. This is to melt the oil really. The oil gets very thick and doesn't come out easily. So the warm compresses help liquefy the oil. Then you do a lid margin scrub with a moistened cotton bud, because many of these gland openings in these inflamed lids are caked shut with these secretions. So you need to break those off before the oil can come out. And then we physically massage by trapping the lid between your finger and the globe, above downwards for the upper eyelid and below upwards for the lower eyelid. And this manual method works quite well. But typically, the patient has to spend about 15 minutes every night, and he has to do this for an average for about 3 weeks to get the relief that is required. And therefore, for those people who can't be bothered to do this and who don't mind spending a bit of money, we have mechanized devices like the Lippy Flow, where the warming of the lid and the massage is done in one session where you just sit like a spa and then it's done. And then you can get benefits ranging for between 6 months to a year with this. It's a little expensive, but for those people who don't want to sit at home and do all this massaging and scrubbing and so on, this is an option that you have. If you have less oil because of the Sika, various methods have been tried to open up the glands. Something that's been advocated and is being done a lot in the West, in the US, is the probing, and this is the Masket probe. So these are just basically thin stainless steel wires which are inserted through these closed openings and passed into the gland, just like you would dilate a lacrimal canalicular system. And you're hoping that after you do this, the glands will be able to excrete the oil on the surface. And sometimes in people with severe conditions like ectodermal dysplasia, everything is just squeezed shut inside, so nothing can come out. So typically once a year, you can take these children to the OR and under GA, or if they will tolerate it under LA, you have to physically squeeze all this anticipated stuff out. And then you hope that after this, you can modify the gland behavior, which I will share with you in the next slide, to produce a better quality of oil in these. And these are the manual methods. We heard Dr. Himanshu say that when the lid blinks, that is when the oil gets squeezed out onto the surface. And in some people with very lax lids, like in the floppy eyelid syndrome, you can even consider in desperate situations surgery, which has been suggested to tighten the lids and reduce the horizontal laxity, so that when these lids blink, they can now function to pump the oil out onto the surface. Now, this is about the quantity of the oil if you have excess or minimal oil. The next important thing is the quality of the oil, because the oil changes in meibomian gland dysfunction due to the bacterial co-infection of various other causes. And we can traditionally treat it medically by using azithromycin ointments. Azithromycin has a role on this. You can use oral doxycycline on other macrolides like tetracycline or erythromycin or azithromycin or orally as well. And these are done not so much so to reduce the bacterial effect, but to modify the quality of the oil that is being produced in the meibomian glands. And despite the recent DREAM study, I still think that the omega-3 fatty acids help in the more severe kinds of these, and I do use them in the more severe versions of meibomian gland dysfunction. And so this is as far as the medical therapy is concerned. Recently, we have the pulse light that can be used, and this is called the IRPL, or the intense regulated pulse light therapy. So what is basically believed here is that when you apply the light to the periocular regions, basically there is a stimulation of the deep nerves that goes on. And when this happens, these nerves then are able to modulate the function of the meibomian glands better. Now, this is derived from its use for acne rosacea in dermatology, where it seems to work well. And this is a serendipitous effect that has now been developed. And the IRPL treatment works quite well. Now, this is not to be confused with the Lippy Flow. The Lippy Flow is a device that is used to express the excess oil out, whereas the IRPL is used to basically modify the quality of the oil, and you'll have to do some kind of physical expression to get rid of the excess oil as well. So these are two complementary technologies. They don't necessarily have to work independent of each other, and sometimes they may even work by combining with each other. And the IRPL that we have been using for the past, I think, 6 months now seems to work well, particularly in patients who fail medical therapy. And this is a good addition to our armamentarium for managing this condition. So for the inflammation part of the meibomian gland dysfunction, we use topical steroids. We use tear substitutes to keep the surface flushed and clean. And we use cyclosporine A in the chronic situation. And this is how it starts. Initially, you will see the inferior corneal peripheral vascularization. If you don't treat it at this stage, it goes on to these flictanules of staph immune infiltrates on the cornea, which migrate gradually towards the center. And if you still don't manage them, the infiltrates can actually perforate. But if you catch them even at this stage and treat them with the lid hygiene and with the steroids and tear substitutes to reduce the inflammation, everything quietens down. And by continuing to maintain the lid, you can keep this from recurring as well. For meibomian plus disease, basically, you can also now use intralesional steroid injections into these chalasia if they're recurrent, rather than cutting up the lid multiple times. This can be done with some lignocaine jelly on the surface and just inject a dilute or 50% dilution of triamcinolone 10 milligram per mil. You have to inject it with a little pressure. Part of the way it works is by increasing the hydrostatic pressure inside the chalazion and causing micro breaks in the wall. And then the anti-inflammatory effect of the steroid helps the body come in and cut away the material that's inside the lid. If you have the associated Demodex, you can use some of these herbal anti-dandruff shampoos, which contain about 5% of tea tree oil. So you do a scrub of the lid margin for about 4 or 5 minutes, and you can wash it off after that. And this scrub allows the tea tree oil containing medication to go into these the meibomian, and this keratin seen in desperate diseases, typically like advanced Stevens-Johnson and OC. We're not going to manage that, but they will also be associated with meibomian gland dysfunction. One of the things that we have available now is topical vitamin A ointment, which can be used to treat this kind of dysplastic change of the lid margin. Basically, meibomian gland dysfunction is a very common entity in Asian eyes. It comes in various forms. It is to recognize the different types, like I tried to share with you. Because if you can understand the pathophysiology, then you can work up a nice treatment regime, which is partly medical. And now with the newer procedures that we have, like ARPF, you can use those to modify the gland dysfunction. Thank you very much.
I think, Dr. Rao, that was a class, actually a master class in meibomian gland problems. And I guess, as we all know, that meibomian glands is probably one of the leading causes of why patients are presenting to us in our OPDs, and most of them are dry eye patients. And I, a lot of times, would like to add something here. Patients with a borderline MGD, post-cataract surgery, is going to be one of the most unhappy post-cataract surgery patients. Now, what I've seen, we have a dry eye unit and a dry eye vertical in my organization, with being taken care by me and my cornea people. One thing it has done for the audience, they must understand, I get patients operated from fellow colleagues, fellow other clinics, 6/6 surgery probably better than me, but the patient's only complaint of, after surgery, I'm not happy. There is some problem. There is some irritation. I feel there is a foreign body in my eye. And once they come to us and we take them up for dry eye management and give whatever relevant therapies required, guess what? They get their second eye done from us. And the poor earlier surgeon who had no contribution to the ailment of the patient, but in the patient's mind, it was problem created by the cataract surgery. And the end result is, so everybody needs to be well informed and aware of, dry eye as a diseased entity and its management. Dr. Rohit, I'd just like to bring you in again on this issue of meibomitis and MGD. Anything else you would like to add? There's so many things available with, cyclosporins and chloroquine and azithromycin. There's a gamut of things, and I don't think there's any other better person than you to, just throw a brief light on that for us.
I think if any one of us, I mean, I'm sure all of us would have very patiently and very closely, if you've heard Dr. S.K. Rao's talk, I think it was a wonderful talk which covers up virtually everything. And after he speaks, I don't think anybody can add anything. I mean, it was so beautifully and simply put. And what I'd like to say is, one thing is, I believe strongly that the doxycycline and all those things really have a role when your lid has vascular issues, telangiectasias and those stuff. That's when your all your inflammation is very high. And apart from that, I think the second aspect I would say is, I don't know how many of you in the panel would agree. There was a time when dry eye was, especially the evaporative dry eye, had a very clear distinction of inflammation was not inflammation. But in the cities where we are in, I would say that 99% of them are driven with inflammation.
Absolutely.
So there was a time we would wait for a year. We used to come second or third time, and then think about starting them on restasis or cyclosporin drops. Now I'm in a stage where we start much earlier, because once it reaches a stage, then even all these drops may not work. And I just want to ask the panel, Dr. Fogla and S.K. Rao sir, about this. Do you really believe in starting them early in your practice? Because Chennai, Hyderabad, Bangalore, and Delhi are all the same kind of a practice.
Go ahead, Rajesh.
I think it's important to look at it preoperatively. If you feel that preoperatively, if your patient has some element of meibomian gland dysfunction, you should institute therapy before the cataract surgery and continue post cataract surgery as well. Don't think that by doing the cataract surgery, your job is done and then you just give your routine medication and expect the patient to be happy with just using lubricants. One thing I have found is that sometimes after the cataract surgery, because you have the restrictions of not applying water to the eye for about a week,
Yes.
patients don't really clean their face. And then if you're using drops, which tend to precipitate or crust on the lid margin, it kind of worsens the pre-existing meibomian gland dysfunction. So that thing about cleaning the eyelashes and using a cotton bud and sterile where you do lid wipes, that has to be emphasized to the patient in the post-operative period.
I think that's a very valid point, Dr. Rajesh. I agree with you. Most of these patients, they have inbuilt notions of no water inside the eye or on the eye. And we, in my practice, on the 7th day onwards, we tell them to have a complete wash, face wash, and eye wash. But I'm surprised that patients, even after 1 month, in spite of it being written in the discharge summary, and most of the patients who will complain of an irritation or a foreign body sensation or a dry eye would be the ones who actually, as you hit the nail on the head, have not put any water on their eye and the eyelid
Yeah, so
hygiene
that's
is
why
bad.
in the post-operative instructions, after a week, I usually recommend nighttime warm compress to the eye, at least for a month or two, irrespective of the fact whether the patient has meibomian gland dysfunction or not. By doing that measure, they feel that you have given them some instruction which is simple to follow. And even if they are not, cleaning, doing lid scrubs or anything, doing that warm compress at nighttime definitely has a regulatory effect on the meibomian glands and keeps it much functioning better than otherwise.
Yeah. Dr. Natasha, your comments?
I absolutely agree, and congratulations on the talk, Dr. Rao. It just summarized everything so well. If a PG student just listens to your talk and write an essay on
MGD.
MGD, it was so beautifully described. So congratulations on that.
Thank you.
And just to add to this, I think we're seeing the similar conditions in LASIK patients, just to take a leaf from cataract patients also. LASIK patients, especially the ones with flap, they tend to have, they just don't tend to touch their eyes because they feel the flap is going to get dislodged. So what we have also started doing is we try to assess for MGD beforehand. And if they have MGD, we treat them with either intense pulse light or lippy flow, and then take them up for LASIK. And this is something that I learned from Dr. Rohit when he had described this in one of his talks, and I found that the patient outcome was much better. In fact, their post-operative medications have also reduced, so I don't have to continue steroids for a very long time in such cases.
Yeah, I agree. You see, I got this idea from Rohit also. Whenever I have a patient whose borderline symptoms dry eye and is in for a refractive surgery, we take them up and make sure that the symptoms have actually disappeared, their OSDI scores are better, and then take them off for surgery. Because once the surgery happens, they will tend to blame the surgery and the surgeon.
Absolutely.
And the whole thing gets deflected, and the next thing you have is what I have with my cataract patients walking up to me. They will send their relatives for LASIK to somebody else and blame the surgeon. So I think that's a beautiful learning. There's a beautiful learning. And this tip, again, I attended one of Rohit's sessions and I picked it up from him. I really follow what Rohit says. A lot of them are, sometimes they might sound very far out and very distant, but what he says, but it comes up with a lot of amazing clinical and scientific experience and insights. So I guess this is a very, very interesting thing. So I guess now the next speaker is Dr. Natasha, and she's going to be taking us through the journey.
Doctor, because it's very bad rains out here, so I don't know when this internet is going to go. So
okay, should I take you up before that?
So I think it's so bad that it can go off any time. So
we'll take Rohit. Should we use the opportunity to introduce you first and you start, because you never know when you lose the connection.
It's okay, sir.
Okay, so
can I share my screen?
I think, yeah. I'll just introduce you. We can't have you coming on without introduction.
Okay.
So can you see the screen now?
Yes, sir. Absolutely.
Okay. So here comes the big guy himself, and I think I really look up to him for a lot of good ideas and the way he analyzes situations, problems, and looks for solutions. The best part is he looks at a problem as an opportunity to solve it. Unlike most of us, we look at a problem as a problem and a hindrance. What he looks for in a problem is he looks for a solution hidden in the problem, and that's the way I think that's what a translational scientist and a clinician, a diehard clinician he is. And I don't need to introduce him. He's one of the chief mentors at the mentor program in Naran Netrale. And I guess, wherever Naran Netrale today is, I keep sharing with my fellow colleagues and all colleagues, wherever I see NN today is, I think a lot has to go to Rohit, what he's done with the organization. And he just kind of put rocket boosters in the organization. And I think every second publication coming out from India, probably in ophthalmology, has Rohit or Rohit associated with it somewhere or the other, or maybe one of the people who gave the idea. He's done path-breaking work in biomechanics and stromal molecular markers in refractive surgery. And he's won the prestigious Colonel Rangachari Award and overall best paper at conferences and Casbier Award at IRS. And over to Rohit. I think we will be in for a treat right now. So over to you, Rohit.
I will share my screen.
I hope we don't lose the internet while you're on.
Hopefully, this is so. Can you see my screen?
Yes.
Yes, perfect. Thank you, sir, for a very generous introduction. I'm not sure how much I really deserve it, but thank you for it, and thank you, the My Healthscape, Monish, and the team for giving me this opportunity. And thanks, Dr. Natasha and Dr. Gaurav, for allowing me to speak before you. These are my financial interests. I don't think it's going to have any impact on my presentation today. We've had some very nice talks on dry eye. How much do we know about dry eye of today, especially with the new normals? New normal or old normal, but there is a huge amount of conflicts about how much we know. These are two patients, which I'm just using new data, which was just a week back, 2 days, 8 to 9 days back. You can see that the T-buds of them were, of normal quality, and Shermers were normal, mild MGD, they're not serious. And look at their OSDIs, both of them extremely bad OSDIs. And this is something which was very alarming, because they don't have any signs but they have tremendous amount of symptoms. And we treated them with the same medications, like the previous talk, sir mentioned about we even treated with an EI for them, the IPL, which I'm going to come back to you. But like Dr. Kamal sir said, the question is about why one person improved. It's not about statistics, why this guy improved and why the same person did not improve. So this is where the whole crux of this situation is, that we need to figure out what was really different. And when you look at clinical ways of evaluating them, you hardly find an answer. So we went a little deeper. The person who did not improve had this extremely different nerve loop areas around. We call it as a microneuromas. Very classic of, it's like schwannomas or in any of your nerve endings. So these are all nervous, bulb-like features in your nerves, and extremely painful. And the patient just keeps coming off pain and irritation in many places. And unless you do a confocal, you'll never pick up. But these patients, there was no neuroma, but you can see those dendritic cells. And these are one of my favorite cells, because I worked on it for the last 15 years, because these are the ones which bring in a lot of, they're suggestive of inflammation. And people who know me and who work with me know that we work on the tears, just like how you do the blood. And this is very interesting, very, very interesting thing. And you will realize it at the end of my talk, why this slide is interesting. What is important here is the patient one, which had exactly the same OSDR pain and all that. All her inflammatory markers were all normal. And in this patient, all her inflammatory markers were high. So it means that the patient A had no inflammation, the patient B had a lot of inflammation. And this patient got better because all your drug, whatever you're treating, is treating the inflammation, and you're treating, and here there is nothing to treat. So you're using cyclosporin on this, but the cyclosporin is acting on something which is normal. So if you're using IL-6 blocker, IL-2 blocker, there's nothing to block because patient does not have inflammation. But in the same thing, if you're looking at this patient has a very high IL-6, and look at the MMP9s, which your doxycycline and other things work. When you use a doxycycline and other things, they work on these factors. Look at the MMP9 is 30,000 and 10th on here, MMP9 is normal. So what is happening is when there's nothing to block, the drugs don't work. When there is something to block, the drugs work. So that is the most important understanding from these cases. And this is what I mentioned. Your nerves are unhealthy, and so you have to treat him like a neuropathic pain. And here you treat him with your drugs. So as ophthalmologists, these two cases are very, very important because they highlight some very important aspects of when treatment works and when it does not work. So you can use in this patient, I'm sorry for spoiling the screen here, but in this patient, you can treat whatever drug you, and that is what is important. You treat 100 drugs and the 100 different drugs will not work. So that is what is very important. And there are multiple ways of evaluating this. What is most important is, I'm not going to go into too deep of this because I think Natasha is going to cover, this is the question which Dr. Kamal asked in the morning. How do you look at the optical quality of a tear film? How does it see? There's a system called OCAS, which looks at the vision tear film breakup time. Basically, what it does, it is like your abrometer, but it looks at the aberrations from your tear film from the first blink, and from your first time it blinks at 0 to what happens till you blink the second, till you do the second blink. So from here to here. So in that period, you can see the seconds here, 2 seconds, 1, 4, until around 20 seconds. What really happens to your tear film? If your tear film is perfect, it should be in that green zone. And when you have this is, you have a problem. This is what happens when you imagine this patient is your multifocal IOL guy. And what happens is you have made him have so much of scatter, and you scatter, and every time you start looking at, have I put it in the angle alpha, or is the kappa longer, or should I put it in, is it on the visual axis, non-visual axis? So there's so much of discussions revolving around the optics of the lens and the optics of your bag, but everybody fails to understand that there is something happening on your tear film itself. And the tear film is probably one of the most unstable thing which creates all this problem. And so when you look at this, you can imagine how much the tear film has an impact in your quality of vision. Confocal microscopy I just mentioned, and these cells are the ones you're targeting it. And if you have this kind of a cells before your surgery, once you make your incision anywhere, this increases, and this can have a huge impact. And I've mentioned about this, that these are the most important thing which creates tremendous amount of impact on your quality of life and quality of vision, and you're non-responsive to treatment. These are all factors which are important. And this is last 17, 18 years, this has been part of my work. And when you look at refractive surgery, most important thing, which sometimes it is, we talk about many things, but we miss the epithelium. And thanks to MS39, now a new tool which looks at the epithelium to stroma. And the most important thing, what I like, is it gives you a new feature, epithelial Zernike. It has never been done before. That means it gives you Zernike polynomials or aberrations from the epithelium. Why is it so important that epithelium is to us now, to as a refractive cataract surgeon. That's what I'm going to talk in the next few slides. A healthy eye with a good ocular surface has a good epithelium. This is an unhealthy ocular surface. Unhealthy ocular surface has tremendous amount of change. You asked me a question, what happens with the biometry? If you are doing a biometry on this patient, let's assume he's got a cataract, there's no cylindrical power here. That means it's a healthy eye. So cylinders also comes from an epithelium if it's irregular. And the whole of cornea is perfect. Imagine this patient here you're doing a biometry. The patient has close to around 0.5 to 0.8 diopters of astigmatism from the epithelium itself. And imagine epithelium is a dynamic process. It can change the cylinder. You assume that if the patient has a 2 diopter cylinder from the whole optical system, around close to a diopter is coming from the epithelium. And this is because there's a huge amount of coma, and this is because there's a whole amount of epithelial irregularity. So what really happens is that these have a huge impact both in the cataract surgery, also in the refractive surgery, especially if you're doing a contura. One of them, you can see the amount of changes. This is all poor ocular surface. The machine is the laser has to treat on the stroma, but the machine assumes that it has to treat the whole thing, and your whole amount of cylinder, what you see, is coming from the epithelium, and these are all very poor ocular surface. And this is just a small diagram explaining about the importance of stromal surface and how the stromal surface can impact your quality of vision. And all this has what I'm trying to say is all this has a huge impact on your quality of life and quality of vision as a cataract and refractive surgeon, because poor epithelium means poor lipids, poor meibomian glands, and that can translate. I'm not just looking at what happens after you do surgery. I'm talking about what happens before, when you're evaluating, because this point was raised by Dr. Kamal in the beginning about what can happen to your biometry and multiple things. Same thing with your cataract. You can have a perfectly normal topography here. Everything is normal, and your normal tear breakup time, the surgery is done, and then the patient starts having problem. And every time we look at the eye, the optical system, but here again the same dendritic cells, and look at this patient who has these kind of preoperatively kind of cornea, who have a very poor ocular surface, they have a very poor heavy dry eye, can end up with these kind of system post-operatively. And this is the kind of tear film optics you can get. It drops down, and the quality of vision is always poor, and you can't really treat them after surgery. And this is again a problem with your epithelial cylinder. And here also, post-operatively, you still end up with some amount of a residual cylinder after few months, because when you use all these technologies, we know how it's changing. This is what happens when you treat a patient without taking care of his dry eye initially. You have a normal looking OSDI, and you can see that when the OSDI increases, the nerves are not healthy. You operate and their epithelium is bad. These are all pre-op patients. You can see here, these are all pre-operatively patients. Once you do a LASIK surgery on them, especially with the nerves like this, a healthy one, decent, and this is poor, you end up with the nerves like this. This is what happens. This is post-op. This is around 6 months. Your regeneration is good. This is decent. And look at this. The nerves are just not regenerated. And look at this. This is what guys who are going to come. So basically, you have to catch them at this stage where you should probably try to treat them and not just jump into a surgery and end up into a problem. And because if you do the post-operatively, they are completely, look at the epithelium here and look at the epithelium here. Look at this, the whole irregularity out there. So that means your nerves, ocular surface, and all this is a beautiful dynamics which can mess around with this. And this is a word I use in my room. This most dangerous phrase in English is that we have always done it this way. And the different ways of treatment. One of the ways I want to bring in the EI, it's like in laser pulse-based therapies. And I'm sure Natasha is going to speak about it. You use 5 flashes on the lower lid, and the way it acts is it's a small video we had done. As you know, it uses through the zygomatic nerve, and then your trigeminal complex and your efferent pathways, which goes to your lacrimal, and it goes to your the lid, the meibomian glands, and just helps in trying to bring in simulation of this nerve. So it's actually working on the nerves which supplies this glands, which brings in tears in your nerve fibers, in your lipid layer. We did down work on your operative dry eye, and these are the number of patients. Inclusion, exclusion is something similar. And we found that, of course, we don't really expect it to change, but there was a change in the OSDI. And what is important is pre and post, there was a huge drop in your OSDI, and that is what is very important for us. We wanted to see if it really works. We brought in some molecular signature work, and this is work done by Sharon. You can see that all those cells which are responsible for bringing in a lot of pain, irritation on all of them have actually reduced, which means that there's a lot of change happening out there. And this is one of those which I showed why we need, because these things has to be blocked by procedures like EI and all these factors. The last part of a few more slides. This is one of my oldest case. This just came 4 or 5 days back. It's a pilot by profession. This was in 2009. This case is very important because a lot of people who know my work, at 2009, we didn't even have a lab. We didn't have anything. But I was still very passionate about collecting the tears without knowing what I'm going to do with it. And we had done a confocal microscopy and all that. And this is 2010. He had come, and 2009 was this is the case file of that. So interesting factor here is that this is a keratoconic guy. And because he was a pilot, I didn't want to operate him because he would lose a job. And I kept him serially following up for a long time. He was stable. And from 2019 to 2020, he started showing this change. I was a little surprised because it was something very drastic. And this is a time he was no job because he was off job for some time. And you can see that the nerves had all these cells, which I mentioned, which the inflammation has set in. Now, interestingly, what had happened was it was actually a if I had just used a pentacam, it would look like there is a progression. But actually, it was not a progression. It was actually an epithelial change. You can see the change from here. That is where the MS39 is a huge new revolution in topography, because it gives you everything at one go. If I had a pentacam, then this is what it would look. If it had, and now I know it is whole of this change is induced by an epithelial hyperplasia. And this is a beautiful case, which means that it was just the factor of dryness there, an ocular surface change, which made him change. And I did his tear cytokines was higher, and this was a keratoconus guy, and he was staying. And these procedures like EI or one of these things, what happens is it reduce the inflammation, and you can see that these inflammation, this is not the same patient, but you can see that when these inflammation get reduced and you don't see them on this, all of them gets blocked. What happens is your inflammation actually gets blocked. And this is where I'm saying is, this is a great procedure before you do. Now I use it even before I do a cross-linking or eye rubbing, if I'm waiting for something. So it's just more dry eye. The various other areas where you can, basically it is reducing your itch factors, which is one of the most important thing in your practice. So it is very important to look beyond just dry eye. And it's just an ocular surface discomfort is what we need to see. And to sum up, dry eye has an ocular surface impact, has got ocular surface disease, has an impact in every known procedures. Treating them before you do any surgery is probably the gold standard. And even when you are having patients with glaucoma medication intolerance, or you have patients with keratoconus with eye rubbing, or pre-PRKs, or any of these procedures, I think I would use these procedures because it's a fast acting and nobody has time to keep putting drops for many, many days. So these are all this I have anyway summed it up. It's got a huge role in pre-refractive surgery. Thank you.
Thank you, Rohit. I think that was a beautiful summary. You just breeze past everything. You make everything what you do sound so simple. And yet I know there's a lot of hard work, sweat, and thoughts and ideas which go into it. And I tend to agree with you. I picked up this idea again from you. Earlier, when I had that EI machine, I was only taking up the extreme and the chronic patients, because maybe at that point I didn't have much faith in the way it would work. And over time, I started taking my even early dry eye patients, because I realized, I heard one of your sessions, that it's apart from the dry eye, it's the rubbing, the mechanical irritation which tends to aggravate it. And to my surprise, I'll be sharing a little bit of my data, that even the mild dry eye cases with the therapy, they became absolutely fine, because I took away that little irritation, which was probably prompting them to rub the eye, itch, scratch, and cause more counter inflammation. So I think that's another great leap from your book. I think by the time we've finished, I won't have much to speak in my session, because everything will be covered. So I'll be breezing past fast. Dr. Gaurav, is Gaurav there? Dr. Gaurav? No, I don't think he's there. Dr. Rao, I just like your take on what Dr. Rohit has just said regarding the health of the epithelium, and the way it concentrates everything in it and around it. Dr. Rao also is not here.
Basically, health of your epithelium is driven by health of your corneal nerves.
Mm-hmm.
So if your inflammation, if your nerves are healthy, it's a beautiful hemostasis. They are all connected. The epithelium need hemostasis control from the corneal nerves. So one of the factors is when the nerves are poor. That's why when you post-operative healing, when the nerves are poor, your epithelium heals irregularly. And now with this new technologies we are seeing, we can even measure the epithelial cylinders. How much does the epithelium contribute to your cylinder compared to your total?
Absolutely.
And which probably we would never really think about it in the past, because for us topography is everything.
So a lot of times when you have a bad epithelium, so by this discussion, would it be a better idea to go in for a surface ablation, take away that epithelium and let it grow back again, than go for a flap bait procedure?
If you have a bad epithelium and if you have a high OSDI,
Mm-hmm.
that is a highly inflamed eye. If you do a PRK, even if you use mitomycin for 3 minutes, which we nobody uses, you'll have a scar.
Uh-huh.
So if you have a bad epithelium with the poor, very high OSDI, with the poor ocular surface, you wait for 4-5 months, treat him
Before
well,
you take it up.
then do a LASIK, then you do a PRK, because you burn yourself very badly on treating on a very inflamed eye.
Mm-hmm. Dr. Fogler, your take
I think
on what Dr. Rohit just said?
Absolutely, I agree 100%. I agree usually with most of his points.
No bone of contention.
See, the thing is, especially what happens is when you do a cataract surgery, especially with a premium IOL, and your patient is unhappy, and post-operatively when you see, and you find that there is some astigmatism which was not there pre-operatively, you should not be in a rush or a hurry to go ahead and do a PRK or a topo-guided treatment to try and remove that.
Mm-hmm.
Because often it is because of the surface irregularity. So as Rohit mentioned, that first treat the surface, your problem is most likely it's going to go away. So I'm very cautious, especially after any of these situations. Even if the patient comes to me for a second opinion and looking for a solution to get rid of that, I always say that I explain the situation to him, do all the necessary tests, and start therapy, and then we reassess at 1 month, 3 months to see that whether these findings are remaining consistent or is there any variability. And then you take a call on whether you need to do an additional procedure. And in a majority of them, I find that you actually don't need to do a second procedure. You can treat the ocular surface, and as this ocular surface improves, definitely the patient's symptom goes away.
I think I couldn't agree more with you. The reason why probably ocular surface is actually shot out into our purview also is because surgically probably we're reaching the level of perfection, and the patients being more demanding today
Correct.
There is even slight amount of symptomatology or visual aberration, they come back to us much faster and with a larger bit of complaints.
Correct. Because
Deeper into what's causing it.
see, those days when you used to see advanced cataracts, total cataracts, patients were happy even if they had 618, 612 unaided. They used to thank you. They used to be very grateful. They never used to complain about dry eye because that visual transformation itself was so significant. All the remaining symptoms used to go away. Now you're operating on cataracts which are 6.9, 6.9 plus, and they are not as symptomatic as what a total cataract would be. So for them, I think although there is the visual improvement, the rest of the symptoms, they desire that they should not be present. And definitely patients are more demanding. So even with a monofocal, your patient wants good distance, intermediate and near vision. So you have patients come in, they get, despite whatever you explained pre-operatively and tell them this is a monofocal lens, when they come for glass appointment, they always have this, but I can't see for near. Or if you have aimed for a little bit of myopia, given them for near, I can't see for far. So somehow that they don't want to pay for the premium, but they want the premium outcome.
Absolutely. I have an anecdote on that. It's a true story. It happened with me 8 years ago. I operated an old lady and she had told her son that she wants a multifocal with a lens where she can read and see distant also. So if the son came with choice, we did the relevant test, we did the surgery, and after the first day post-op, she comes to my chamber that she's very, very unhappy because she cannot read. So I looked at her autorefractometry and she was 6 by 6 parts unaided, and I said she should be able to read. So she's telling her son that the lens is not right because it's not doing what it's supposed to. So I asked, Maji, kya problem hai? She says, padha nahi ja raha hai mere se. So I said, padna to chahiye because aapka distance vision theek hai. So then the son laughed. He got the joke and he told me, sir, Maji ko padna aata nahi hai. So she heard from a friend that ye lens se aap pad bhi sakte hain. So once she thought she'll get a multifocal, so she'll be able to read also. So that is the level of what the patient expectation. And this is a true story, happened to me 8 years ago. And I still tell it to all my associates that you never know what the patient expects from you.
So it's always better not to promise, 20/20 or 6x6. Yes. I always, no matter which patient I operate, I always tell the patient that, see, all eyes cannot be the same. There will be anatomic variations. Despite the best of intraocular lens power calculation formulas we use, the measurements that we do, we may be very accurate, but your eye anatomy may be on the outlier side, So you can sometimes have, so there can be, so if you don't explain to them pre-operatively, post-operatively, if you try to tell them the same concept, they think that you have made a mistake and now you're trying to cover up by saying it. So some of these things about dry eye and, so you say that, okay, 95% you will be unaided 6.6, but there is a 5% chance you may be a little bit on the plus or minus side. If you fear that by saying that your patient is going to go away, I think rather lose the patient than to have the post-operative headache dealing with the patient. So for that, I think it makes my life post-operatively much easier if I am very frank about all these things pre-operatively and, counsel them about that.
I think that's a very good carry-on point for a lot of beginner surgeons in their practice. And I think the one punchline word I use is that 95% of my patients, 95% of the time of the day do not require glasses.
Correct.
For most of their daily routine. For something fine here and there, you may require glasses.
So I tell my patients with multifocal lenses, I told them, you will get good vision, functional vision, but you will not get the perfect vision. It's not possible.
Absolutely.
So if you're looking at a perfect vision, that all the time you should be able to see for far and near, then don't get a multifocal done because it's simply not possible. The technology has not reached that point.
Yeah. Dr. Kishore Pahuja, final comments before we go on to Dr. Natasha. Sir, you're unmute.
I totally agree with Dr. Rajesh said. Patients' expectations are very, very high. You have to, sort of downsize their expectations. Once you do that, and after that, patients are happy. Even if they read 6.6, they're extremely happy because you have already told them that your vision is going to be like this. I 100% agree with Dr. Rajesh said.
Wonderful.
The only thing I would like to add on, sum up on this is when you mentioned that you're perfected the art of surgical techniques, but we are still very, very little understanding of biology.
Absolutely.
Biology is so poorly understood, and we assume that our surgical technique and the lens and whatever we are doing is going to. So, for example, that's why I posted that case that one had a microneuroma. I mean, we are a research institute, we have a luxury to do all this. But if you don't, then you'll always be wondering, same kind of a problem, why one patient gets better, the other one does not.
Yes.
And the second thing is something which was stable for 11 years of stability of a keratoconus suddenly becomes progressive. And the culprit is not in your topography, culprit is because you have a dry eye. So these patients, of course, every patient is important, but these patients, I take it very, especially the one I 11 years, because a small judgment error is a matter of losing his job forever. Because if I do a cross-linking on him, he cannot fly. So that means that we have to be very, very cautious in understanding every bit of biology, because only then I think it gives a picture. Because biology is playing a different trick, like the coronavirus. Whatever you do,
True.
it has
No, that's why whatever procedure you do, no matter what the track record is in your hand. So I never promise 100% to my patients. No matter how good I can do a procedure, I can tell them that always there will be a small element of uncertainty. So I give them the opportunity. If they want to say, I don't want the procedure, I don't want to make the decision for them tomorrow when something goes wrong. The patient then comes back and says, you never told me, explained to me the risk clearly, or you were the one who made the decision for me for the. So I think it's very important. If my patient asks, can you be 100? I always tell them there's always a risk of uncertainty. There's something can go wrong, but we will try 200% to make sure that we, overcome that and we give you the best of care.
Yeah,
So unless they
right.
understand.
Yeah, that's right. I mean, see, we are so advanced within our formulas and in our biometers and this and that, but still we are just fighting within a ELP. I mean, it may be any different from one patient to another. So, I mean, still we haven't found a solution for that. So that's what Dr. Rohit says. This is basically in a biology or that anatomical change that is going to happen. We never know that who patient is going to have it.
Yeah, see, the biology, as Rohit said, one of my favorite sentences is, I'm a good carpenter. I can make an excellent bed. But how you sleep on it, what kind of sleep you get on it, and how your husband gets it is entirely what is your sleep pattern. I can give you the best bed possible. So most of the patients do tend to get it. So I guess after this, we'll go to, I think we are running short of time. Dr. Natasha, I think now I'll just start with the introduction of Dr. Natasha here. I'll just start the screen share. Can you see my screen now? Can you see the screen? Can you see the screen?
Yes.
Okay. So here comes the little big girl, Natasha Pahuja herself. She is one of the very dynamic speakers and very, proficient surgeon. She's a cornea specialist. She's working in Pune, more than 30 plus peer-reviewed publications at her age. She is one of the youngest PhD in keratorefractive surgeries, and I've had the opportunity of hearing her out at a lot of conferences, and I never cease to get amazed with her knowledge and her ability to communicate and connect with the audience. I guess, the environment she's been nurtured in with Dr. Pahuja and Dr. Rohit Shetty has got a lot to do. And of course, her own dynamism comes into play. And I would not even have the courage to go through all the awards and honors. And I think if I go through them, she'll probably be finishing 1/3 of her talk during that. But, the big ones are the Moscone, YKC, Pandit Award, ASCRS 216, Best Paper Refractive Surgery, APCRS 216, Best Paper Refractive again, ESCRS 216, AIOS 216, and the list goes on till 2018, WOS International Hero Award, ARVO 2018 Travel Grant Award and a paper as a hot topic of the session, and AIOS, which is the recent one, the International Hero of India again. So over to you, Dr. Natasha, and I think we are looking forward to what you have to speak on the dry eye diagnostics.
Thank you so much for that kind introduction, sir. At the outset, I would like to thank Dr. Kamal and My Healthscape for giving me this opportunity to discuss and deliberate a little bit about just one sec. Yeah, to discuss and deliberate a little bit about how we are evolving with our dry eye diagnostics. So evolution here being the operative word. So no matter what is the stimulus for our evolution, we are still evolving, like managing a pandemic like COVID-19, or to a simplest thing of discovering a new tier substitute. We are constantly evolving. As I said earlier, no matter what is our stimulus for evolving, when we want to see the evolution, let's just take a step back and see our past and our history. So as Dr. Gaurav Luthra earlier mentioned, that dry eye disease was earlier just defined as the water within, and how they were treating it was as this is in Egyptian scriptures. They used to make a paste of myrrh and lead salt. That's why they have this thick eye makeup that the Egyptians had. And I think this is where Professor Stephen Flugelfelder got his idea of nasal stimulation from, that some of the cultures, including India, used to use incense sticks to cause reflex lacrimation. So defining dry eye disease with just a three-word definition to almost calling dry eye disease as a short note now, we have come a long way in how we have evolved in understanding dry eye disease. So earlier we was just to concentrate on the diagnostics. We used to just classify dry eye disease based on Schirmer's test and TBUT as it is aqueous deficient or evaporative or maybe mixed. But understanding how multimodal the disease has become, I think the diagnostics also have to graduate from our simple Schirmer's and TBUT to a multimodal diagnostics. Now to make it very, very simple and concise, we are going to approach this in a very stepwise manner. And the stepwise manner is going to be thus. We're going to look at the history and questionnaires that are available for dry eye disease, the clinical exam, which is absolutely important, and finally coming to the investigations. Let's start with the questionnaires. Now, this has been detailed by Dr. Gaurav Luthra earlier, but what he highlighted was very important of the facial washing, how we do it. Most importantly, we have also started including this in our leading questions as to if the patients are smokers or if they are passive smokers. So if I had this friend of mine whose husband was a smoker, and because of the passive smoking, she developed significant dry eye disease. So these are few things that need to be asked in history. Now here is a list of validated questionnaires that are available for dry eye disease. They can vary from the number of questions that you have. What is important here is that if you want to look at the quality of life that it has. Now, I cannot have an OCAS or a HT analyzer at my clinic. So to understand the visual impact that dry eye disease has, I can just do a simple ocular surface disease index, which takes hardly 5 minutes to do it. But if you want to do a detailed questionnaire, which also decides of how the treatment satisfaction has been, then you can go to an Alcon IDLE questionnaire. So these are validated questionnaires that are available. As soon as the patient is done from preliminary, step 2, we give them a questionnaire depending on if I want to diagnose dry eye or if I want to prognosticate dry eye treatment. Step 2, after doing the history and questionnaires, the most important aspect here is step 3, which is the slit lamp or the clinical examination. Most often than not, most of the diagnosis is done at the slit lamp, and it makes our life so much easier. Just by understanding what kind of dry eye disease the patient has, as was beautifully described by Dr. S.K. Rao in his talk. But how do we objectively understand this and then take it forward to the patient? So objectively quantifying this is where the investigations come into play. Now the investigations can be either understanding the structure or the function aspect of it. So how do we classify them? To understand the function, it can be a non-invasive TBUT, as Dr. Himanshu mentioned, or it can be a tear meniscus height. The interferometry understands the functional component of the lipid layer. It quantifies the lipid layer as well as it understands the quality of lipid layer. But to understand the actual structure, which is the meibomian glands, you would have to do a meibography. So to do the TBUT, there are these available diagnostic methods. To understand or to objectively quantify interferometry, we would use a LipiView. And to look at meibography, any infrared device could do the job, be it a topographer or a keratograph. The common link in all of them that I have been using currently is the IDRA. So what IDRA does is basically it combines all of these machines into one. So let's take it step by step. So this was the user interface. What it does is it gives us the interferometry, and it gives you the video. Also, it makes it very, very simple. So it gives a tool and a colored scale which will tell what is the lipid layer thickness, and it will also say that objectively it is normal, suspicious, or abnormal. And the metrics are inbuilt into the system itself, so we don't really have to memorize the numbers. Then the next it does is the tear meniscus height. Again, it gives the same measurement, and it objectively gives a report of this that can be given to the patient a little later on. After the tear meniscus height, the cone can be changed into a Placido image. So the cone, the reflection that is seen from the Placido cone basically gives us a graph, and especially areas which have got poor tear film breakup time. Now, this is a non-invasive method, so you don't have to instill fluorescein into it. But what it essentially does is, based on the, as the time progresses, it gives us where the tear film is breaking up. So it also tells us localized where the problem could be. The step 2 would be actually touching the patient, which is done in meibography. So essentially what it does is it not only images the meibomian glands, it also gives a comparative score. What we can also do is manually instruct the patient, the clinical examination that we have done previously, by pressing the expression of the meibomian glands. So by squeezing, we understand how many glands were open and what was the quality of secretion that came out of it. So it also puts it into a regression analysis and gives us an objective score of what the meibomian gland is. Furthermore, they have made it a little more fancy by giving us a 3D reconstruction of the entire meibomian gland that is available in the newer software. So it makes us truly understand anatomically where the structural changes have happened in the meibomian acini. Furthermore, it can classically take very good images of what kind of blepharitis the patient has, and it is very important in prognostication. When the patient follows up after medical treatment, we can image these lid margins and truly classify as to if the treatment is working or not. So essentially, at the end of it, the step 4 gives us an absolute clear one-page report, which tells us what is the NIBUT or the lipid layer thickness, or how the meibomian glands are, what is the gland loss, percentage of gland loss, if the treatment is working or not, and the follow-up treatment can be added into it. Furthermore, objectively what we have measured, the osmolarity, can be included into the system, and it gives you a regression analysis of the entire treatment. So we have understood the structure and the function, but what we have not looked at is that how is the tear film, what is the tear film composed of? Now, we cannot take all the tears to the lab immediately. So what we can do is look at the tear osmolarity. What it essentially does is a step 5, which will tell us that if the tear film is has increased osmolarity. Also, it can also tell us if the tear film or the ocular surface has got inflammation. Now, these are clinically available tools. Tear MMP9 costs about 1,000 to 1,200 rupees and can be done in the clinic. Also, what is important here is we don't have to absolutely look at the pink color that comes into the positive. A slight change in the hue is also important as a positive tear MMP9 treatment, positive tear MMP9 on the ocular surface. So essentially, why is it important is because in the entire key mechanism of dry eye disease mechanism, we are basically able to diagnose the hyperosmolarity and the inflammation aspect is sitting in the clinic. So after this would be the step 6, where you are actually going to touch the ocular surface so that the previous measurements are not altered. So this is the simple Schirmer's and TBUT that can be done. The TBUT is done to assess the lipid layer function. The other test that can be done is the phenol red test, which is less invasive and takes lesser time than the Schirmer's test. And of course, once we have stained the ocular surface, it would be vital to look at the staining technique. Again, what is an advantage with the IDRA is that it gives you a corneal color which is correlating with the corneal staining. So we can have a reference image and then we can add it into the reference into the system and give us a final output of where do we stand in classifying the patient's dry eye disease. So having said that, these are patients where we have almost most of our patients who have classical dry eye disease will be qualified and will be treated accordingly. What is important here is the patients who are symptomatic but have no signs. So these are the patients who come with these typical complaints that, my eyes are tired, my eyes are hurting after cataract surgery, as has been discussed earlier also. So these are the patients who have these unexplainable pain, and we know that there is the effect is the pain, but the cause behind it, what we have understood till now, is that there is inflammation. So when we looked at inflammation, you just type inflammation and vitamin D and you get more than 460 papers on inflammation and eye and vitamin D. And what is very important here is that we have understood the role of vitamin D in the immune system of the ocular surface, as well as in the systemic immunity. And what is even further important is that we have proved it and validated that vitamin D is important. And following Professor Rohit Shetty's talk, he made my job so much easier, because he's highlighted the role of dry eye and dendritic cells that are present on the ocular surface. What it also does is it causes changes in the nerves of the eye. And how do we measure? This is the step 7, where we can actually measure and quantify different layers, which is done by the in vivo confocal microscopy. The important one here is the subbasal nerve plexus. So combining all of these, we are able to take it step forward. Now, this would be a luxury, and it is an important research tool where we can collect the tears that we have done from Shermer's and collect the serum, and a combination of all of this, if we can send it to the lab, we will have a more insight of understanding the dry eye disease, which may help us give better treatment to our patients. But clinically, what is currently available is these are various studies that have combined what are the emerging diagnostic technologies for dry eye disease. I have put up a chart here which basically tells us which layer of tear film are we looking at, and what is the best way to evaluate that layer of tear film. Now, why is it so important? Is simply because our treatment depends on what we are diagnosing and how we are diagnosing. So depending on which layer of the tear film is involved, we go ahead and treat that layer of the tear film. Just a passing remark on why diagnostics are important, just not in a cross section as diagnosis, but also the follow-up as a treatment. Now, this was a patient, this was actually my brother who was undergoing the IPL treatment. So he had a significant amount of dry eye. What was very important here is that I did a pre-IPL for him. The meibomian glands looked absolutely disturbed, but if you look at the pre-IPL, he had, I cannot explain this, but he had a lot of meibomian gland dropout. But post-IPL, after 3 months, he had regeneration of, if I can really classify it that way, he had regeneration of meibomian glands, which I have not seen so far. I've not even heard of so far, but this was like absolute miracle. Fortunately, he was my brother, so he was very happy, and he sent me 4 more patients after that. And I was very, very fortunate to contribute into the atlas that was published by SPM and IDRA. It was a clinical atlas. So it just increased my interest into diagnosis of dry eye disease, and the entire process has helped me understand and given better insight into what dry eye disease is. To sum up, it is very simple. It just looks like it just looks too much and too messy and too much to grasp, but it's very simple. Step 1, take a detailed history. Step 2, give a questionnaire to the patient, depending on which questionnaire you're comfortable with. Step 3, do a simple slit lamp examination, and this has to be in this order so that it is non-invasive and we're not disturbing the ocular surface. Step 4 is the non-invasive methods that we have described already. Step 5, touch the ocular surface, look at the tear film composition in terms of osmolarity or MP9. Step 6 is the clinical test during which you would instill fluorescein stain or lissamine green stain, the vital dyes, to improve our diagnostics, and which we are actually more comfortable with as clinicians. So this just validates what we have done in step 4, which is the non-invasive methods. Step 5, if none of these are working, it would be vital to look at the systemic workup of these patients, because there could be something more which is just not apparent on the ocular surface, or as we call it as the white inflammation or subclinical inflammation. And if you have the luxury, you would go to step 8, which is the advanced diagnostics of looking at fewer biomarkers or systemic biomarkers, also looking at the confocal imaging or OCAS. I would like to conclude this by thanking my mentor, Professor Rohit Shetty, who has just induced too much curiosity, which has helped ask too many questions. And I'm sure Dad and Professor Shetty get the brunt of it by asking silly questions. But thank you for making me more able. Thank you very much.
By the time we are over, I think it's an amazing presentation, very lucid, and you practically, I think, summed up everything. There's nothing much left for me to speak, so I'll be actually flying across, and we already running very short of time, so I'll be passing straight to Gaurav. We've overshot, and I think it's time for dinner. A lot of people would be leaving, so over to Gaurav, and Gaurav is going to be talking about the use of money blades in his femto cases.
Thanks, Kamal, and fantastic talk, Natasha. I really enjoyed your lecture, and especially the summing up slide as well. And Kamal, you've actually made my job easy, because your talk on the blades was so good. I have actually cut short my talk in few places just to restrict it to what I'm speaking on. So I'll just share my screen. In fact, Kamal's talk was fantastic. He covered all the small points, and I could, actually remove a few of the things that I didn't want to speak on anymore. So I'll be sharing my experiences with making incisions with the keratomes versus the femtosecond laser. And so how would you like your incisions? Now, if you do topical anesthesia, phaco or flax, you would probably be doing clear corneal incisions. So I'm going to restrict myself because, over the period of last 20, 25 years, I evolved from making SICS incisions with, crescent blades and, onto limbal incisions, and then going on to clear corneal incisions a long time back, and then evolving with the corneal incisions as well. So ideally, good incisions would be easy to make with minimum resistance. Precise, it should be a square incision, well placed, non-leaky, well sealing. Now, problems with bad incisions, I cut short these slides because Kamal spoke so well about all the possible complications you can have. It can lead to a complicated surgery, and very rightly said by Dr. Himanshu that, residents who are learning or phaco beginners, they actually are the ones who probably need the best, keratomes, because, if they have a compromised incision, their surgeries are going to get more and more complicated. You could have leaky wounds with, shallow chambers and surges and everything. And if you had a tight wound, you would get wound burns. So, having the right keratome of the right size, giving you a predictable incision every time is so critical. Then, if you had poor keratomes, and I've seen that happen. I've gone through post-graduation. I've gone through the situations where, for purposes of economy, we would reuse our blades after autoclaving them. So I think over the time, I realized that no compromises on, my keratomes. Even if you end up spending a little extra money and charging more from your patients a little bit, you really need good keratomes for yourself. So no irregular incisions, sudden entries, and I'll show you a couple of videos of what can happen with that. Now, most importantly, in today's world where we are aiming for perfection, astigmatism, either inducing astigmatism with your incision or having a bad incision which you need to suture, can both compromise your surgery. Decimate steers, Kamal spoke so well, and they can be a big problem with blunt instruments or poor quality keratomes. And of course, if you have a very bad incision, you could have inflammation, you could have endophthalmitis. So I started using in the late 90s when I was doing SICS, I really started enjoying the Alcon knives for making my corneal, my scleral tunnels. The crescent, I remember, used to be of extremely good quality, but then that time we had no choice. Then in the early 2000s, we moved on. We started, playing with the diamond and sapphire, looking at some of my top surgeon colleagues who were using these blades. And soon I realized that, they were not really as good as they, looked on these videos that we see. And we moved on to other blades like the sharp points and the BD I used for many years. Dealt with a lot of Indian blades, which are pretty good actually. But, I think the blades that we currently use are in a class of their own. Moved on from all these blades. 2015 or somewhere around that time, we started doing femto-assisted surgery and started, using the money knives as well, maybe a year later after that. So here I wanted to share some instances of which will tell you what all can happen with a poor blade. Now look at this. This was a post vitrectomized eye silicone oil. Now just see, it looks very innocuous, but see what it's done. Sudden entry, and I have an intumescent cataract which is now punctured here. So it was in a flash of a moment, and then it was gone. And you now have a situation where you could have possibly a flag sign, and you could have complications there. Now let me take you to another small situation where here this is a patient, I think, where we are planning to do an ICL. See how easily the side port blades go. It's a nice money blade which is being used. And for the main port, for ICLs, we actually use a 2.8 a 3 incision, which probably I think money was not making. For some reason we were using something else. A disposable Indian blade was being used. And just watch what happens when we make the main incision, because you need a slightly larger incision for the main port for ICL, whereas for cataract I use a 2.2 money double bevel plate. Now here we are going to make the main incision, and just watch as I try to make it. It's probably not of that good quality, and as I try to make that, just see that it's become a little difficult, and it goes suddenly. Now just imagine if I was to go and puncture the anterior capsule of this patient where I'm planning an ICL. So it's so critical to have a good quality keratome for all your patients, whether be it cataract, be it ICL. You would probably want to do the best. Now, looking at some problems that we faced with the femto, like femto, I love the femtosecond laser, and I really enjoy using it for all my complex cases. So nothing against the femto. I really use it as my first choice surgery for so many situations. Yet when it comes to corneal incisions, I think over the years what I've learned is that if I want a predictable, good quality incision, I have actually in the last 2-3 years stopped making my incisions, because for many reasons. It saves a lot of time, because the planning and the placement of the incisions on the femtosecond laser, then also trying to open those incisions, many times they'll open effortlessly. And then there will be other times when you're doing a VIP patient, you're doing a trifocal lens, trifocal toric, and then you suddenly have an incision which didn't open correctly. And just watch this video as it proceeds. Let me take you to the point where the incision is being planned. I'm sorry for that. Now here we are planning the incision, and we've gone ahead with the incision. Look at the incision over here. The planning is done. Now as we execute it, I'm going through with the lens fragmentation. Just watch the incision over here. Can you watch this? Can you see that there is this skip area over here? It made it all the way from here till here, skip area. So sometimes, even if you identify the limbus right, the femtosecond laser, because it's OCT guided, may make the incision, either too anterior or too posterior. And then you may have situations even with the side ports. So look at this, what happened with this incision. My incision came right onto the conjunctiva over here because the laser falsely identified the limbus. I have to abort that incision and go in with a new incision. And you can see that making this incision is so much simpler and straightforward. So going on, there was another situation here where we made a femto incision, and I'm going to try and open that. You can see that sometimes these incisions will not open as you would like them to. And even though I've got into the correct plane, you can of course go wrong with the planes and so many other things. And then, you can sometimes have to actually complete your incision. And these are the cases where you may actually have a poor entry wound. Now look at this. I'm trying to close this incision and I'm sealing this. Now you can see the gap here. Can you see this gap over here? This incision is not great. It's going to leak, and it's probably going to induce astigmatism as well. And I hate incisions like this. This is the reason why, even if you get like 1 or 2 incisions like this, just see it's leaking. I'm not happy about it, and I'm trying to seal that again. And maybe in the end I'll manage, but if you don't, then you have to do something about it. Another small situation where I have a good looking incision, and I think I'm happy about it. I'm going to do well, but I'm now dissecting the vertical part of the incision, the first plane, and then I get into the second plane. Bit of a challenge sometimes. Now just watch what I did. Just go back and see, when I entered that plane, I pushed the descendants here actually. So sometimes that inner lip will not be so perfect, and as you try to dissect the plane and get in there, you may produce a small descendants attachment there as well. And then you want to actually open up the incision completely on both sides. So after years of doing this, I realized that my incisions with these keratomes that I currently use, the money ones, that they are so much more predictable and good in their construction and anatomy. I decided that I don't need to make incisions. Look at what happens now. I've injected the lens and continuously continues to leak this wound over here. Exactly same patient where you can realize that my wound is main port is leaky, and I'm going to have a trouble trying to get that lens in and then trying to seal it. And here, as I seal it, you can see that I have to struggle. Most of the times, as Dr. Pooja said, when I make my incisions with the good quality keratomes, I don't even have to seal my main ports. I can just seal the side ports and get away. And here, you're actually struggling. You're doing a quality surgery. You're doing a trifocal lens, maybe a toric, and then, you don't want to compromise on your incisions. So this is what can sometimes happen. You can see this inner lip over here. And this is what I don't like sometimes about my femto incisions. And so there can be also a lot of contraindications where, if you have a pannus, you have corneal opacities, you have a radial keratotomy patient, you have peripheral corneal thinning, compromised endothelium. I remember reading a study, where they did some studies on the endothelium with femto assisted versus keratome, and they were suggesting that, don't use high energies on, doing the corneal incisions. Now, this is again another study which was published where, they've compared a keratome incision versus the femto incision at 1 month. And you can see that the femto incision somehow, although it is nicely triplanar, has not, still healed from the internal. The anatomical healing is not as great as the other one. So another situation where I've done RK, I've done a femto assisted RK also. My choice of surgery is a femto assisted. Just see that the incisions are making good use of triplanar. I actually enjoy making them. Just see less. Watch here. I'm not even stabilizing my
Gaurav, you need to kill the volume. Gaurav, you need to kill the volume. We can't hear you.
Can you? Okay. Just watch that. I don't even need to stabilize my globe with a counter pressure. I'll just make the main port incision very precisely. There is no stabilization of the globe, and the blades are fantastic. So it can actually give you an excellent. And just watch the end of the surgery. As I finish the surgery, I do a trypan blue Seidels test to watch my main ports. Now, RK incisions, you can understand, are difficult to make, difficult to handle, and then difficult to close. But as you can see here, these incisions feel seamlessly, and I really enjoy making these incisions with my keratomes. So another situation where we are using femto assisted surgery, but using the money blades, which I prefer to use today. And we can reuse them a few times. It's not probably recommended, but for sakes of compromising on the cost that we incur, we do plasma sterilize a couple of times. But I won't recommend it. But off label, I can say that they still continue to work beautifully after a couple of autoclaves as well. And you can do a good surgery there. You can again see that here with minimal pressure, it literally kind of, I have to actually hold my hand back because it goes in sometimes so fast that you have to be a little careful. Another situation where we are doing a black cataract, and probably the same thing. So let me go on. I think Kamal is waiting for his dinner. So to summarize, a good steel disposable keratome, I think, works much better in my hands than the femtosecond laser or even the diamond knives for predictable, safe incisions, complication-free. Choosing the right keratome is so critical to a good surgery and avoiding complications. And with that, I think I didn't bore you too much.
No. I think Gaurav, the videos were just apt. The presentation was crisp, and I think the point went really home. That even I will share that last 2,000-3,000 femtocataract surgeries, I am 100% blade. I am not using, even if, of course, when there's a pannus, there's a corneal opacity. Yes, agreed. That's how I actually started using these blades. In fact, that's how money came into my organization, because in my femto, a lot of times I had a scarred cornea or a pannus or a vascularized cornea. I would not attempt to create an incision. But over time, I realized the ease of, doing a keratome-based incision is far more controlled and predictable than using a femto. And now we've stopped using the word bladeless. Earlier, we were calling it bladeless. So we reworked it. We told our counselors that it's a femto laser-based surgery.
Right, same here. We started calling it laser-assisted cataract surgery.
Absolutely.
Or laser-assisted cataract surgery. No bladeless.
So I think this is all we all are agreeing. I can see Natasha nod her head. Dr. Kishore, just one or two points. Do you agree with me?
Yes, true. You see, as I told you that, I mean, when this J&J people came to me and they said, you are the place where we are going to install it. I said, for what? I mean, only for the hard cataracts. And I said, I don't do any hard cataracts. And then incisions are my money blades.
Dr. Himanshu is there, or he's gone?
Kamal, I think the mark of a good blade is that you don't need to use counter pressure to stabilize a globus.
That's right. That's absolutely right.
If you want
Absolutely
to take out
right.
a blade which is good, you
Yeah.
just have an eye which is, patient fixating on the light, and you go with your incision and the eye doesn't move. And that's what happens with these blades that
Yeah, that's what I showed in my presentation. And the best part was the first video I showed was a patient who required a 3 diopters of IOL. You could actually see the IOL stand vertically
That's
in my
right, yeah.
hydroinsertion. But these eyes are the worst. They are the scleral rigidity is bad.
Yeah.
That the wound would 100% collapse or leak. And I showed with this blade the wound does not leak. So even in a
Correct.
3 diopter IOL and such a myopic eye with low scleral rigidity, it was a breeze. So
same thing, Kamal. And when you said that, you no longer make triplanar and you evolved to biplanar, I said he's exactly doing what I'm doing last few years.
Yeah.
I no longer bother to make a triplanar. They work so well with the biplanar incision. You just dip in at the last moment, you just dip in your septum and you have it going through. Amazing.
Okay. So I guess I'll be going very fast. I think before I do that, I need to introduce Dr. Fogla because, he's one of the panelists and he's one of the esteemed panelists. And Dr. Fogla, I don't need to actually introduce, but he's one of the biggest names in cornea when it comes to this part of the world. He's the director of Cornea Clinic, senior consultant at Apollo Hospitals. He's the past president and founding member of Cornea Society of India. That's huge. And, especially in cornea and external diseases, cataract and refractive surgery. He's involved in teaching and training. And, I've had the opportunity of, just attending his sessions, training sessions. He's a fantastic teacher and he's very well versed with whatever's going around in the world. And he's a fantastic cataract surgeon also. He's got innumerable presentations in peer-reviewed journals, and he's the reviewer of international journals, the Cornea, Ophthalmology, American Journal of Ophthalmology, Eye, Journal of Cataract Refractive Surgery, BJO, JAMA, IJO, and whatnot. That's huge. And the Achievement Award of AO, APAO, Gold Medal Award for Intraocular Implant and Society, and the list goes on. And he's an innovator, and he's designed several surgical instruments to simplify corneal surgery. And I'm sorry, Dr. Fogla, I couldn't,
He's an excellent cook. He makes fantastic stuff.
I have never got to do that.
I've enjoyed all his cooking and he's amazing.
I'll catch him next time. So I think I'll go breeze through very fast. I'll actually try and wrap up whatever everybody's done. I'll just sweep through whatever Natasha has done, Dr. Rao, Dr. Fogla has discussed, and of course, Dr. Rohit Shetty. Again, no financial relationships. And I guess nowadays you shouldn't be walking around this. So I think this is the way I should have been. Now that looks better in COVID times. Okay, so let's see where the.
Sir, could you share your screen?
It's not. You can't see the screen?
No.
Funny. Just do that again. Okay. Can you see that?
Yes, now we can.
Okay, so we just do that. So I will just start again. I'll sum up and wrap around in nutshell with templates. How to optimize the treatment protocols for the patients, the diagnostics, how to derive inferences, simple OPD procedures, advanced diagnostics. Of course, we mere mortals don't have access to the kind of equipment and technology which Natasha has access to at Naran Netralaya and Rohit. But we'll try and see what we can do with whatever we have. No financial disclosure. And as I said, this is not the way to be. Even this photograph, the mask is not in the right way method. It should have been like this, COVID times. So let's see, what is the future market of looking at, the commercial angle, the dry eye market, what does the future look like? What are the opportunities available for us to treat and benefit our patients and impact their lives? And there are reports, there have been conferences specially held on this with Allergan, Novartis, Santen and all. And 218, they did a conference where they predicted that by 2014, the dry eye treatment market, especially let's look at our area, is going to go up by 47%. And henceforth, across the world, the average boost in dry eye cases, treatment modalities, options available, pharma, diagnostics is going to be average up by 50% in the next 3 years. The pathology in nutshell, as we all know, excessive evaporation or secretory issues. I'll be going very fast. The tear lipids, as we all know, they help to keep the tear film stable from evaporating. Mucin actually anchors it and spreads it across. And water, of course, water layer takes care of it. Now, each part is done by a different gland. I'm just kind of summarizing whatever has been done. The oily components is done by the lipid secreting meibomian glands. The risk factors, let's look at the ophthalmic risk factors. You have blepharitis, excessive contact lens wearers, demodex, dry eye disease, which is caused by, post-LASIK, chronic uveitis, systemic factors like androgen deficiencies, menopause, aging populations, thyroids, Sjogren syndromes. Vitamin D is really coming up very in the bandwidth of everywhere for all of us. Last year, I attended a session with Rohit, and after that, I started performing this test regularly in my dry eye clinic, and I was fairly surprised to catch a lot of vitamin D associations. Psoriasis, atopy, medications, patients on anti-androgens, benign prostatic hyperplasia, BAK containing eye drops. A lot of times the eye drops themselves are culprits, especially in a post-cataract patients. Patients are using a lot of drops, and that bad lid hygiene together is a good mixture for the dry eye to actually flare up. So BAK containing preservatives, anti-glaucoma medicines are well known to cause dry eye. Antihistaminics, a lot of these patients will be going to a general physician, which I've seen. They'll go for irritation, redness, and watering of the eyes. And guess what does the general physician do? He gives them Avil. He gives them cetirizine because he thinks it's an allergy. And guess what? It's a bad mixture. The patient gets aggravated dry eye. So at least 7 to 8% of patients in my clinic, if they visited a general physician, are on anti-allergic. Can you believe that? So once I have trained my optometrist to take histories of oral medication and specifically ask for anti-allergic medication. So I'm surprised 7% of patients are on some anti-allergic medication for watery eyes and irritation, which to a general physician probably it makes sense, but for us it's sacrilege. So a lot of antidepressants also would aggravate the situation. The current pattern probably of dry eye would be starting with aqueous eye drops, gels, and as the disease severity keeps going up, we have punctal plugs, retreatments, surgical options, topical steroids, cyclosporins, chloroquine drops 0.03%, meibomian gland massage and stimulation. The biggest problem is a lot of us are just treating the patient with a lubricant. And that's the toughest thing for a lubricant to take care of all the issues. The lubricant will have to take care of the viscosity, the surface coverage, inflammation, and a lot of other factors, irritants. So one single lubricant will not take care. So the second thing I've seen is a lot of these patients come to me with one antihistaminic and a lubricating dry-off given by the general physician. And sometimes these lubricating drops are off the shelf available, and they have guess what do they have? They may have BAK in it. So that's another ignition to the big bomb blast. So all these things are happening in the market. So once you have a keen eye to catch these things, you'll realize that these things are aggravating the patient's problem. And as I mentioned, we've gained a lot of fan following in the patients from fellow neighboring clinics because they do not have dry eye clinics and dry eye specialists. And these patients are saying, Dr. Kapur, we've been going to this clinic for 4 months. My problem is still the same. And I've come here and now I'm feeling better. Now I want to get the second eye operated here. Now that adds to a lot of goodwill into the market. So let us come to the fact that let us all agree that meibomian gland dysfunction is one of the largest causes of evaporative dry eye disease. The pathophysiology, as we all know, is going to be like there's a hyperkeratinization of the whole pathway. There's increased viscosity, which causes obstruction of the meibomian gland orifice. It leads to intraglandular cystic dilatation, dropout, atrophy, low secretion, and then it causes lesser meibomian gland available. Then it starts causing an evaporative dry eye because there's a tear film instability, hyperosmolality, and you have bacterial growth and inflammation. So this is what the cascade of the whole thing would look like. This is a way you would probably want to measure or quantify your MGD. I'm going very fast because I realize most of the things have been discussed. I'm just wrapping it up. The main symptoms of the dry eye probably are stinging, burning, stringy mucus. A lot of times patient would come and say, Doctor Sahab, aankh se dhaga nikalta hai. And I would wonder what's wrong. Till I finally saw the dhaga one day. And I saw it on the street lamp. Because the lady would come and say, Doctor Sahab, aankh se dhage nikalte hai. So I could never figure out that what they're referring to is mucus, because, the stringy mucus. So eyelid redness, difficulty in wearing contact lenses, nighttime driving, paradoxical watering. So when you tell this patient that you have a dry eye, they refuse to believe it. They say, Doctor Sahab, dry eye kaise hai? Pani jharna nikalta rehta hai. I have a tap of water flowing out of my eye. So such patients will take you not very seriously, but you need to sit. So what we have is we have a little video, a 45-second video, which tells what does the tear gland do with the blinking movement, and then another 2-minute video of the general meibomian gland structure and animation to make the patient understand. So the core mechanism, as we all know, in the end, it's the increased cytokinins and hyperosmolarity, which increases the inflammation. Different questionnaires to be employed. Most popular is the OSDI. You employ these questionnaires to quantify and to see the direction and see the progress of these patients. As Natasha has discussed it beautifully, so I will just jump this again. Now, these are a few patients. You can see, the slit lamp photographs. We take these slit lamp photographs and show it to the patients. We tell them, you see, there is a froth. So I tell them that, what would you feel if you had soap in your eye? So they say it'll burn, it'll water. So I tell them this is what is happening. You have kind of soap in your eye. So when I tell you you have soap in the eye, it is watering. So the watering is in reflex to the soap in the eye. You're actually, the eye is dry, and they get it. And we show them these photographs. And once the treatment is over, they're doing better. We take comparative photographs, and we on my EMR, we save the old photographs on that folder date, and we compare the photograph and show them to them. So you have non-invasive tests, which can be done on simple slit lamp. You do dry clinical evaluation. You have tear film height analysis, debris, mucus strands, fluorescein, rose bengal, lysamine green, Schirmer's 2. These are all tests which are done in a particular sequence, as Dr. Natasha beautifully explained them. They are done in the OPD. Now, why we are doing these tests is, number one, to diagnose the patient. Number two, to quantify the degree of the disease. And number three, to map the progress or improvement of these patients. So once you keep doing these tests and noting them down and showing the results to the patient actually starts feeling better. Again, the clinical characteristics, as I said, as MGD is one of the leading causes. Blepharitis, gland dropout, seborrhea, repeated chalazions is another condition. A lot of patients will come to you with repeated chalazions. They may not be exactly manifesting the symptoms of a dry eye to start with. The change in the alteration of the Marx's line. Now, you could actually check the functionality of the gland. So what I do is I have connected my slit lamp with a television screen in my OPD. So a lot of times when I push the eyelid margin and those white serpents of toothpaste come out, I show it to the patient's relative. So they are actually amazed, because they can never imagine that something like this would come out of the skin. So I tell them this is like coconut oil frozen in winters, and it is not lubricating your eyes. So now they understand the importance of giving hot fermentation. Because I tell them that if you do hot fermentation, this frozen coconut oil will start moving. It's obstructing the path. It's not lubricating your eye. So we use a lot of these examples and vivid simulations in our OPD to help the patient understand. Meibography, again, Natasha has explained it beautifully. You can quantify the amount of loss of meibomian glands by the surface area. We use cirrus mapping, and also in our SBM and IDRA. The approved dry eye treatment menu is start with artificial tear substitutes, gels and ointments. Omega-3 is still a little bit of questionable role, using of punctal plugs, avoiding offending agents if the patient is on eye drops and BAK. Anti-allergic medications can be used. Tea tree oil. I've recently started for a few months this tea tree oil in these patients with blepharitis and Demodex. I'm very, very happy with this. Using of bandage contact lenses, moisture containing spectacle glasses. Now, I'll just jump fast now. Now, the preservatives themselves are a huge culprit. So when you're trying to optimize the treatment for these patients, you need to decide what is the kind of preservative the drop you have. Even if you're giving an adjunct dry eye treatment, but there are some other concomitant eye drops being used by the patients, you need to know what are the kind of preservatives you're using. BAK is notorious to cause dry eye and toxic. It's very toxic to the epithelium. Now, selection of the artificial teardrop. Preservative artificial teardrop could be used in a moderate to severe dry eye with high viscosity gels. Artificial teardrops with HP guar is ideally suited for evaporative dry eyes. Sodium hyaluronic acid has greater hydration, more than 50% of times the water retention. Rebapamide is a drug which we use very frequently when there's a special mucus deficiency. Now, these are the serpents I was talking about. Now, these serpents are very, very ominous of a chronic MGD. Warm compresses really helps these patients, improving the eyelid hygiene. And as Dr. Rohit said, doxycycline, azithromycin, a combination of cyclosporins, chloroquine drops, and surface drops, they help these patients. Now, what the reason why I'm trying to touch all these is they all would make a complete umbrella of treatment of the dry eye. Most of the times, a lot of surgeons are just putting them on methyl cellulose or polyethylene glycol and thinking the job is not happening. Now, new horizons are, hormone replacement therapy, artificial reclaiming gland, vitamin therapy, and now I'll be talking about light pulse therapy. I'll just jump to that. Now how do we start diagnosing? I'll jump the video. I'll just, in interferometry to actually see the lipid layer, these machines are very sensitive. As Dr. Natasha said, in our machine, we can get 3D simulation of the gland, and you are able to assess the health of the meibomian gland. You're able to measure the tear meniscus using this SBM machine. We've been using this. We started using this. First, we bought one of them, and over time, we started realizing that's really helpful in helping my patients in dry eye. So I've started using it in all my centers now, and all our centers are equipped with this machine, and it's really helping. More than the fact that it adds to the revenue, it actually helps you treat your patients, get to understand what is the real problem bothering them, and then you can actually start targeting them specifically rather than just carpet bombing them with whatever you have. Tear film blinking time. Now, these are some of the reports, interesting reports. Now, what happens here in SBM is the report is very pictographic. So every patient is able to understand the report. So once you have a printout, we show it to the patient and we say, okay, now this is how fast your tear dries up. And we tell them that this is a speedometer. The more it moves toward red, the worse off you are. And the more it is with the green signal, the better you are. So I think it's a very lucid explanation which can be given to the patient. So we tell them lipid because they all understand lipid. When I tell them आपके lipid test होना, so they understand it's fat. We tell them आपका lipid ठीक है, but आपके tear meniscus height, आपके आँख में आंसू कम है, there are less of tears. So such patients and such improvement protocols are shown. The patient is encouraged to save these in his file. Now, every time he comes after the pulse therapy or a treatment, we show them the reports and how the improvement is happening. And they are very, very happy and satisfied. Without these images, a lot of times the patient himself doesn't know he's feeling better. But if he sees the images and reports, he's far more convinced. Now, these are the blink measurements. Now, this is a patient whose one eye used to water, and we were trying to wonder what is happening. His other eye was absolutely normal. This is his other eye. The meibography was absolutely fine, but there was an issue with the blink rate. Now, this is an incomplete blink. He's blinking by 55% only. Now, that's what was causing the watering in this patient. So as I said, patient satisfaction is very important. Once the patient actually starts seeing the imagery and the improvement as he moves along. And now coming to this EI technology, I think we bought it nearly 10 to 12 months ago. We've done nearly 250 cases because from March onwards, we are closed down. So we're not doing any. So till March, I think in a period of 4 to 5 months, I've done 250 cases of treatment and followed them over time, and I had very, very promising results. This is based on, regulated pulse technology, whereas the other technologies available are just simple IPL. I'm going very fast. Actually, the difference is this is probably 25 to 30% more efficacious because every 2 or 3 pulses, there's a regulated pulse which gives more energy and the pulse energy keeps changing. Now, most of your patients will be coming in the dry eye segment would be 20 to 40% of your OPD. And most of them would be having some or the other kind of an MGD. So this is what the pulse therapy would work. Dr. Rohit Shetty has actually explained it beautifully. So I skipped those 2-3 slides. So it stimulates the nerves to have more secretions from the lacrimal gland. And it's a very simple procedure. Anybody can do that. You just need to cover the patient's eyelid, put in a gel, and apply 5 shots along the path, the described diagram, and it's got a beautiful response. We tell the patient that do not expect a response within first 10 to 15 days, but most of them, they do agree that they do start feeling better. It could be psychosomatic. So what we've done is we've just collected 250 patients plus. Now this is a patient distribution of the patients we did, 267 patients. Now these patients were mild symptoms, were approximately 13%. This again, I took a leaf out of Rohit's suggestion once, that if I take the patient in the early stage, mild stage, he stops rubbing and inflaming the eye again and again. And they're the ones who actually don't proceed further to get bad. Now, approximately 78% of the patients after a period of 3 to 4 months were better on the OSDI score. They felt significantly better and felt a reduction in their eye drops. Now, this is the patient who started on mild symptoms. Nearly 78-90% were better at the end of 3 months. Moderate symptoms, severe patients, approximately 67 to 68% patients were feeling better and reduction of eye drops. So I guess, thank you. So I guess,
Kamal, I think I'll have to say that what an amazing, I mean, I thought everything had been said, and I was wondering what Kamal is going to talk about, but you found so much to speak about, and also amazingly well placed there. And yes, your experiences with this technology have been fantastic. So I think you did a great job, and I don't have to mention that almost all of us did, unless Natasha, you have any question for Kamal's talk?
No, I'm thoroughly impressed. Like you said, sir, we thought there'd be hardly anything left to speak, but you just brought out such small nuances in the history taking to eventually talking of how the dry eye treatment is much better in earlier cases. So such small nuances were brought out which were clinically so relevant. So thank you for highlighting those points. I just had one question. So how long do you see after doing EI? How much time does a patient need to symptomatically feel better? Like earliest?
Okay, earliest I had my first experience with EI. I'll share with you, and that's where I'll start. It came to me for my demonstration. I have a cousin brother of mine who had a severe MGD. He's been on doxycycline, erythromycin, name a thing. And I did my first session on him just as a trial. The machine was with me for demonstration. So what actually broke my cookie was on the 4th day, I'm a Punjabi. So on the 4th day, he's elder to me, but he says, Pape, I love you. And this man was suffering so much so he was having depression because of his eye. If I would show you the photographs of his red congested eye, he couldn't go for meetings. He's a big businessman. He would wear dark glasses because people would think he's drunk. So that's where I got my first confidence that this was on the 4th day of therapy, first session. Most of the patients on the 10th to 12th day, if you actually probe them, they say, yes, slightly better. But the graph starts taking on after the second therapy.
Okay.
That's where it starts actually kicking in. That's on the 20th day onwards. Second session onwards, the patient themselves with volunteers, you don't need to ask them. 60-70% of the patients, without you asking them, says, Dr. Gur, this time I'm feeling better. Last time you just asked me, so I was forced to say yes. But this time I'm definitely feeling better. So I think I would say oddball figure of anything beyond around 20 days is the time when they start feeling better.
Great. Thanks, Kamal. I think we had a fantastic discussion, and we have very few of us left, and I think our webinar has really been a big hit, Kamal. With you there to moderate it, and with all the fantastic speakers who spoke today, I think I learned so much from this webinar, right from the biometry talk by Dr. Pahuja sir to Dr. To Natasha's, Rohit's talk, to Dr. S.K. Rao's talk, your talks, and frankly Himanshu's talks. Everybody spoke so well, and all the expert comments from Dr. Fogla. We must thank MyHealthscape for actually getting this webinar together. It's broken all records, 3.5 hours running, and then it's still not over. I'm sure YouTube and Facebook must be tired of us. And I only hope that some of our viewers are still with us. But congratulations to Milescape for organizing this, and thanks Kamal and all the speakers today and all the panelists today for staying on so late and doing an amazing job of bringing out science and bringing out pearls from your practices, and maybe helping some of us understand things better, how we do them. And with that, I think I would like to thank all of you one last time. And Kamal, if you have anything to add to that, Dr. Pahuja, sir, you have anything to add to that?
I think Gaurav, the way the whole thing went, it was very lucid, and I think this would I would probably market it or sell it to the market as the Bible in dry eye management,
True.
of course, and we'll promote it as that, and I'll keep you all updated how the views are going.
And Kamal, we still have 85 people actually logged into Zoom to see.
Yeah.
I'm quite amazed at that. Yeah. So I'm sure Facebook and YouTube will have many more viewers. And frankly, with all the mine of information which is there in this webinar, people would love to come back to this and like take pearls, take home messages from so many of these talks on dry eye, on everything. Yeah.
Gaurav, if you remember the last webinar we did together, we did 32,000 views in 4 weeks.
I know. With Kamal there, it does that. Kamal, we have to do one with you playing music for us.
I'll do one with playing music, live music. Everybody, good night.
We finished with a few mixes from you, huh?
Yeah.
I think, when you said, Kamal, when you said that Punjabi thing, it sounded so much like Monish for a moment. I was going to ask you, was that Monish? But then I said, stay quiet. I think
good night, everybody. I think it was a pleasure. Dr. Pahuja, the senior Dr. Pahuja.
Thank you very much.
To have you on board. Dr. Fogla, Dr. Rao, Dr. Imanshu, they're all seniors. I really look up, I try and learn from everybody. Rohit is somebody I look up to. I have a different connection with him, even at a spiritual plane. We both think alike.
I think Monish is here. Monish, can you make yourself visible?
Monish, I can't see Monish.
I can see
him. He has joined, but I mean, you can't
I have infrared vision, so I can see Monish there.
So, okay, everybody, good night. And I think it was a great seminar. Thank you, everybody.
Thank you, guys. Thank you so much. Bye-bye.
Bye.
Thanks. Yeah, bye.